patient who might have a sensory loss if these nerves are injured. The other genitofemoral nerve and femoral and obturator nerve comes under lumbar plexus. So genitofemoral nerve is an important nerve which arises from L2 to L2 L3 level. It has two sensory divisions, as you're aware, uh, and motor division to cremastric muscle. The significance in the anatomy is that it enters the psoas muscle from the posterior medial aspect at L2-3 level and exits along the lateral and anterior aspect of psoas muscle at L4-5 level. So this nerve is at risk while retracting the psoas or during the surgery. So other nerves which are at risk are the femoral nerve, which arises from L2 to L4, predominantly helps in hip flexion, knee extension, and the level at which it is at risk, maximum risk, is at L4-5 level. Then rarely obturator nerve can be injured, and sometimes sympathetic nerve are at risk, which are along the anterolateral aspect of the vertebral body. So coming to the applied anatomy of this nerves and the plexus, Morrow had devised something called zones. So he had performed a cadaveric study in 30 cadavers. In 6 cadavers, he did an axial cut section at along the superior aspect of body, inferior aspect of body, and along the disc from L1 to S1. And the remaining 24 cadavers he had dissected to look at what is the relation of genitofemoral nerve over the psoas. So the 6 cadavers, this is the cuts which were made, and in the axial section, the zones were divided into A is anterior, P is posterior, and based on the anteroposterior distance of the vertebral body, it was divided into 4 zones. Okay. So he had found that if genitofemoral nerve was not considered, most of the plexus from till L2-3 level was predominantly in the zone 4 or posterior. So predominantly they were posterior and not at risk. As you are aware, the point of docking for OLIF retractor, ATP retractor is anterior and middle third of vertebral body. So these structures are not at risk from till L3 level. But below this, the nerves tend to come anteriorly, that is to zone 2, zone 1, and sometimes even anterior. So below L3 level, they may be at risk while putting the retractor. However, genitofemoral nerve has a peculiar course that it arises at L2-3 level, and it is at predominantly in zone 2, and at level below it comes more anterior. So that is this peculiar anatomy of genitofemoral nerve predisposes it to injury during ATP approach. So this is the axial cut section at the level of L2-3. You can see that the nerve roots shown by the arrows, they remain in zone 4. Okay. So here it is at L3 at the superior aspect. This is a nerve root in the zone 4, but you can see genitofemoral nerve denoted by this star mark is anterior. As you go below, you can see the nerve roots going anteriorly to zone 3, and you can see the genitofemoral nerve almost in zone 1 or anterior. And at alpha S1 level, this is the femoral nerve which is seen in the zone 3, zone 2 and 3. So you must be aware from L2-3 and above, the nerves are not at risk, and L4-5 and below, you should be careful. But genitofemoral nerve can be injured even at L2-3 level. Then coming to psoas muscle, which is an important structure. It arises from the transverse process of T12 to L4 vertebral body, and it it increases in size as it descends down, and it is quite large at L4-5 level. And the course also, it tends to go anterior to spine as it goes down. So relevant to ATP approach is to identify preoperatively the shape and the configuration. So this is the coronal image showing the psoas major muscle. As you can see, the bulk increases, and it comes anterior once it goes down. So this is the axial section showing the psoas muscle, and these are the lumbar plexus. So this paper described different types of psoas morphology. So there are two types. Either it's a normal morphology like this, or it can be something like a teardrop where it is elongated and more anterior. So this morphology, as you're aware, the corridor for OLF is between psoas and the great vessels. So this is the corridor. Once it becomes anterior, the corridor becomes narrow. And also, if we are retracting the psoas, it can lead to hip weakness. So it is important to identify this kind of morphology, something called a teardrop morphology. This paper described that at L4-5 level, if a teardrop morphology is found, there is a risk of increased neurovascular injury. And this risk does not differ if there is a transitional vertebra. Other papers have described something similar like a rising psoas sign where the psoas has come anterior and has detached. So at this level where patient had a L4-5 listhesis, this patient had something called a rising psoas sign. This is not a normal location of psoas. Level above you can see a normal location of psoas and good corridor, but here you can see the corridor is quite narrow. Yeah. So one is the morphology, and also look for asymmetry. You can see here on the right side the psoas is quite anterior, whereas the left side it is posterior. And also it is the bulk of the right psoas is smaller compared to the left. So this paper describes whether this corridor, does it differ if the patient has scoliosis. So this is the psoas muscle and the lumbar plexus, and these are the great vessels. And so this is a safe zone. So it showed that as we go down from L1 to L5, the safe zone narrows in normal degenerative spine patients without scoliosis. But in scoliosis, there is further narrowing of this safe zone seen compared to a non-scoliotic spine. And also, it differs whether it is a levoscoliosis or a dextroscoliosis. So levoscoliosis scoliotic spine have a narrower corridor compared to a dextroscoliotic spine. So the zones, safe zone decreases from top to bottom, and it is narrower in patients with scoliotic curve. So there's also a structure, ascending lumbar vein, which arises from common iliac vein, which can be injured at L4-5 level. You should identify it and preserve it while doing OLF. So this study by Molinares described the oblique corridor to L2 to S1, which is this. It tells that from the corridor at L3-4 level, it is the maximum. L2-3 is optimal, and it decreases as we go down. And in L5-S1 level, the corridor is only 70% of the cases it was feasible to do the surgery. This is another paper which tells the same finding, that it does not depend on the gender, but as you go down, the corridor narrows. And so we routinely perform ATP through the left corridor, but can we perform ATP through the right corridor? This paper tells that compared to the left side, the corridor is narrower on the right side uniformly over all the levels. Regarding L5S1 approach, ATP approach. So yesterday we had seen the ALIF, L5S1 ALIF, and this is the L5S1 OLIF approach. So what decides whether it is feasible to do a L5S1 ATP approach is the location of the common left common iliac vein. So they described 3 types of left common iliac vein. Here it is in the lateral third of the vertebral body, or it can be floating type, which is favorable. Type 2 is it is reaching towards the midline, that is almost reaching till 2/3. But there is a adipose tissue plane seen on MRI. That means it can be separated. This can still be attempted, the ATP, L5S1 ATP approach. But whereas this, where the common iliac vein is tightly opposed to the vertebral body and reaching till the midline, this left common iliac vein can be injured when performing a ATP approach from the at L5S1 level. So it is important to identify the lie of the left common iliac vein if performing at L5S1 level. Sir, any pointers, anything you? Any other structures you think which I missed?
There are a lot of other structures that can be considered. Sympathetic chain.
Sympathetic chain, yes.
Yeah, sympathetic chain is something that we always see. I'll show the video of when doing the technique about sympathetic vein, which can come into the picture. So there is a consensus that sympathetic chain can be easily sacrificed. In a sense, especially in Indians where the the change in the color of the skin on the left leg compared to the right leg is not going to be observed after a sympathectomy. Usually after a sympathectomy, you expect the ipsilateral limb to be warmer and slightly more hyperemic, right? Because of the lack of sympathetic supply to the vessels in the leg. But in Indians, it is not exactly noticed, and very few people complain of it. But we have seen patients who have come and told that my leg feels a little warm after the surgery. So that is something that needs to be considered. The second thing is ureter. I think ureteric injuries have also been described in the retroperitoneal approaches, and usually it is not identified. Usually it is not. It doesn't come into the picture. But sometimes what happens is, so the facial planes through which the OLIF goes is called the pararenal fascia. That is the anterior to that, not the exactly. So you have the kidney, you have the kidney, the retroperitoneal space is divided into 3. One is post-renal, pararenal and pre-renal. So this goes to the pre-renal fascia, that is PPF. And laterally, there is something called the lateroconal fascia, through which you have to enter and go into that posterior pre-renal phase, the space, and that is the right space in which you have to supposed to enter. And if you go in that, the ureter is exactly just posterior to that, especially when you are doing at L3-4 and L4-5. And sometimes the fascia is so thin. Usually there is a lot of fat and a lot of gap between the ureter and the facial plane through which you are entering there. But sometimes it is so thin, I'll show the video, it is so thin that you can actually see the ureter right in the way. And sometimes if you are not very careful, it can get injured. And especially if you are in the wrong facial plane, if you go into the wrong facial plane and enter the posterior pararenal space, in that case, it is going to get, the chances of injury are higher. So that is something that we always need to take care when doing a posterior retroperitoneal approach. Any questions from your side? We'll be happy to answer.
So do we need to mobilize it anteriorly or posteriorly? Where should we mobilize
Which
it?
one?
Ureter.
No, the ureter is always going to go back. Means it is going to go towards you. That means anterior.
Anterior. Okay.
We are posterior to that. But you're standing on the front of the patient. So you have to pull the ureter towards you. Usually along with the retroperitoneal structures, the entire structures inside the retroperitoneum will go anterior.
Anteriorly.
Along with the ureter, along with that. Sympathetic chain is also something that you need to pull anterior, but there will always be one small branch that goes off at each level from the sympathetic chain, which goes along at the just inferior to the disc. And sometimes that may hinder your retraction of the sympathetic chain anteriorly. So if you just coagulate one small, or if you just sacrifice one small branch of the sympathetic chain, then you will be able to again retract it anteriorly in a good manner. I have the videos, I can show it to you as we go along.
To present his talk, a series of talks.
Good morning, sirs, dear friends, Dr. Surya. Thank you for having me here. And so, as Surya told, he has given a huge responsibility of covering the entire all the aspects of POLIF, or all the aspects of what we call as an anterior to psoas approach. Okay, so मिरर हुआ नहीं अभी हो गया अभी ये हाँ So before we go into the details of the technique and details of the anatomy, I think one basic question we all need to understand. Whenever we start a new technique, the first thing that we need to have is conviction. We should know why we are adopting this technique, why we are preferring this technique over a technique that we have been routinely performing, and what are the advantages or disadvantages that this technique offers as compared to the technique that we have been doing routinely, right? I think that is the first question that we need to answer. Now, if you see, when we started minimally invasive approaches from an open or a conventional TLIF and we progressed towards an MIS TLIF, the only side effect of open TLIF that we avoided by doing MIS TLIF is a reduced paraspinal muscle injury. You know, minimally invasive is not actually minimally invasive, it is just minimal access. The amount of invasiveness to the area of pathology is almost the same as we are doing it in a conventional or open approach. That means you still have to do a complete facetectomy, you still end up on the dura, you still retract the nerve roots, you still handle them, you still do the entire flavectomy, end plate preparation, cage placement, pedicle screws. Everything that you do in an open surgery is still done, but only the access is smaller. That is, only the paraspinal muscle injury is less. So in a MIS TLIF as well, you still have the risk of dural injury, neural injury, epidural fibrosis, postoperative radicalitis, dysesthesias, all the other issues that you are associated with an open or conventional TLIF approach. So how do we avoid all these things? The only way to avoid all these things is to go outside the canal. Means you don't enter the canal. You do these surgeries as an outside the canal approach, and that is something that we can achieve by these retroperitoneal approaches. You can come from completely outside the canal. You don't have to enter the canal. You don't have to handle the nerve roots. You don't have to do any kind of a dissection inside the spinal canal, and you enter the disc through a virgin area between the anterior border of the psoas and the blood vessels, where there are no structures except the sympathetic chain, where there are no structures, and you will be able to do the same job that you are able to do that. And so this is the main advantage. So all the other complications of TLIF also can be avoided with a lateral or a retroperitoneal approach, and that is the main advantage. Now, this is the approach that we choose, as Dr. Surya has already told. You go through the lateral abdominal layers and then you sequentially go dissect through the retroperitoneal fat and enter the surface of the psoas and dissect anteriorly to identify the anterior border of the psoas and enter the disc space in the margin between the anterior border of the psoas and the blood vessels. Now, that is not the only advantage of a lateral approach or a retroperitoneal approach.
Now the cage that we use in a lateral retroperitoneal approach is one of the largest. And as you know, the vertebral body, the epiphyseal rim is in the periphery of the vertebral body, and that is the strongest portion, which is affected later, slightly later in osteoporosis as compared to the central cancellous portion of the vertebral body. And that is why if you put a cage right in the center that you are going to put in a T-leaf, the chances of cage subsidence, the chances of collapse are higher. Whereas if you put a large cage like this, which spans the entire apophyseal ring from one side to the other side, the amount of support that you are getting in this is significantly better. And that has been proven is actually in biomechanical studies as well, that the load failure of these implants are increased by nearly 40% in an intact, and even in a decorticated end plate, it is improved by 30% when you span the apophyseal ring. That is, by putting a larger cage all across from one end to the other end of the vertebral body, the chances of subsidence are lower. It doesn't mean that it doesn't happen, it is just lower. So this is something that we need to understand. There are other advantages, numerous other advantages. One is you are not removing any structure of the spine when you are doing an ATPA. Let me tell that again. Any structure of the spine you are not removing except the disc. You are preserving the facet joints, you are preserving the capsular ligaments, you are preserving the ligamentum flavum, supraspinous, interspinous ligament, you are preserving the ALL, you are preserving the PLL, you are preserving all the structures inside in the spine except the disc. Only thing that you are removing is the disc. So all other structures are preserved. So basically, this is more of a spinal canal remodeling rather than a direct decompression, and that is why we use the term called indirect decompression for these approaches. Then you might ask the question, sir, if there is a compression and we are not removing any structures that is causing compression, how does this work? How are we going to relieve the compression that is there? So this works in different mechanisms in different situations. One is in spondylolisthesis, as you are preserving all the ligaments by just distracting the disc space, you are causing what we call as a ligamentotaxis. Ligamentotaxis, due to which the discs actually, or the vertebral body actually realigns itself into its original position, because the ligaments do not stretch in the oblique fashion. When they stretch, they become straighter. And that is the property of ligaments. That is the property of ligamentotaxis. And that is something that we can utilize for correction of listhesis by doing an indirect decompression. In a lumbar canal stenosis, by distracting the disc space, you are actually stretching out the bulging disc as well as the buccal ligamentum flavum, thereby opening spinal canal dimension. So that is the mechanism by which it works. But by far the most preferred or the most use of OLIF is for degenerative scoliosis. Now, as you see, the degenerative scoliosis, what is the pathology? It's an asymmetric disc space collapse, a lateral listhesis that happens, and a lateral vertebral wedging in severe cases or long-standing cases. Now, all these are reversed by the solution that OLIF offers. In OLIF, you are putting a uniform sized cage all across the disc space. That is the uniform disc space distraction, uniform disc height restoration. So that is why, again, by principle of ligamentotaxis, all these vertebral bodies actually align themselves by just putting cages in the body. Trust me, and we will show you the examples. So basically, when we say lateral approaches, all of these can achieved by both trans-psoas approach, which used to directly, or what we call as an X-lift or a D-lift procedure, which used to go directly through the psoas muscle, versus an ATP approach, or an anterior to psoas approach, or what we commonly call as OLIF. So both these approaches can virtually achieve the same objectives. In both, you can put the same cage. But again, in your previous lecture by Dr. Surya, he has already covered these things. What are the nerves? What are the Morose zones? And how are these nerves placed as we go down from L1 to L5 in the lumbar spine, and how close they are. All these pins are to the center of the disc. How close these nerves are to the center of the disc. So that is why we come more and more anterior. Now, and not only that, as you go inside the psoas muscle, again you see this is the femoral cutaneous nerve. Most of these patients, when we were doing trans-psoas approaches when 2014, 2016, So these patients used to complain of severe lateral thigh pain, groin pain, because of genitofemoral nerve and lateral femoral cutaneous. So both these used to get stretched due to the the dilatation of due to the dilatation within the psoas muscle, which can cause compression on these nerves. Now, the common thing that we used to say in trans-OS approaches is that there is post-operative hip flexion weakness, and this was the incidence, trust me. So and we also used to say that neuromonitoring is very essential when we are doing a trans-OS approach. Means we have to monitor the lumbar plexus. So, and that is why neuromonitoring. But the pathology of these hip flexion weakness was not actually a direct nerve injury. It is psoas muscle edema. And this is what we had observed, that just splitting the psoas muscle, especially if you are doing multi-level and you are splitting the psoas muscle at multiple levels, the edema that results in the psoas itself causes hip flexion weakness, which is not going to be detected by your nerve monitoring. And also the thigh or groin pain, numbness or paresthesias, which again develops in a significant portion of patients, is either due to manipulation of genitofemoral or lateral femoral cutaneous nerves, which again is not going to be detected by your intraoperative neuromonitoring. The chances of a direct nerve injury, which is very, very less common, is the only thing that you can actually identify by routinely monitoring the lumbar plexus in these kind of cases, in the trans-OS approaches. And that is why it is very important to consider the anterior to psoas, that is, you completely go outside the muscle. That is why OLIF is called outside the muscle approach. Outside the canal and outside the muscle means you are going outside the muscle and coming in an oblique manner into the disc space, thereby avoiding any kind of an injury, any kind of a compression on the nerves within the psoas muscle. And even the retraction that we are going to do is not going to put significant pressure on the nerves within the psoas muscle, as I was telling earlier. So this is the plane that we need to identify. That is the psoas. This is after we have put the cage. This is just for representation. And these are all the retroperitoneal structures, and this is a plane, a relatively avascular plane that you can actually develop during this surgery. OLIF also has several other advantages compared to a lateral lumbar or a direct lateral approach. The positioning that we used to use for a DLIF approach is like quite steep. And again, there have been studies which have shown that just making patients lie in this position for 45 minutes resulted in thigh pain, resulted in that much amount of stretch of the psoas happens, that itself resulted in some amount of thigh pain and thigh weakness in these patients, some voluntary patients. This was done in Australian study. So that positioning itself is quite this one. That is why it was emphasized that it had to be very fast. It is to be quick in, quick out approach. You can't make the patients lie in this position for more than 2 hours or something. So that is why it is important. Whereas in an OLIF, you can just make the patients lie flat. You don't have to position it like this. You don't have to open the gap. This was basically done to open up the gap between the iliac crest and the lower part of the rib cage, so that you get more access for a direct lateral approach, because you are right on the mid-axillary line there for your direct lateral approach. Whereas OLIF, you are coming more in the anterior. That is why these two structures do not come in the way as much as it used to in the trans-OS approaches. And that is why the positioning for OLIF is simple. Even for the surgeon, it used to be very ergonomically easier for doing an OLIF. When we are doing XLIF, usually you used to stand on the back of the patient. That means the patient is turned to the other side. You are standing on the back and you are doing. Whenever the C-arm has to come, because your direction is perpendicular to the ground, and the C-arm has to come, you cannot look inside the space when the C-arm is coming, and then the C-arm has to go back, and then again you have to bend and look forward like this. So whereas in an OLIF approach, because you are oblique, you are not directly down, you are oblique, the C-arm can always be there in the lateral position, and you can easily work without telling the C-arm to go back and come back every time that you have to do any kind of a manipulation. And it is very easy, as the picture itself represents, very easy on the image, very easy on the ergonomics for the surgeon itself. Now again, Coming to indications, the second thing that we need to understand when we start doing a new procedure is when are we going to do these kind of surgeries. Of course, by far the most common indication is spondylolisthesis, whether it be single level or whether it be multi-level. I'll show this example later. This is the amount of decompression that we can achieve, and trust me, there is no ligament or disc that has, or the posterior annulus that has been removed. So it is just by putting a cage to distract the disc space that you can achieve this much amount of decompression. So this is the pre-operative and post-operative image of an OLIF case. So this is what it is. So even in degenerative listhesis, even in lytic listhesis, we have done it rarely for grade 3 also, but preferably it is advisable for grade 1 and grade 2 spondylolisthesis, especially those which are not rigid. As I mentioned earlier, lumbar canal stenosis, which necessitate fusion surgery and not just a decompression surgery, can also be considered for OLIF. Now here again, when we do surgery for lumbar canal stenosis, it is important to consider the clinical symptoms. Now that has come in a big way. So we always say that irrespective of the severity of lumbar canal stenosis, now older times when we were doing this, started doing these surgeries, we used to say central canal stenosis, no OLIF, direct decompression. But if the patient has only dynamic symptoms, irrespective, I am telling you again, grade D SHISAS, irrespective of the severity of radiological compression, if the patient has no symptoms at rest, has only dynamic symptoms, that is, patients develop symptoms only when they stand, when they walk, these patients are ideal candidates for OLIF approach, because these are dynamic symptoms and you are just stabilizing the spine so that the abnormal movement or the pressure on the disc, which compresses the neural structures more when the patients stand and they walk, as compared to an MRI which is done in the lying down position, is just a stabilization is enough. And if you are able to distract, even in cases where the disc height is relatively well preserved, even if you are able to distract for 2 to 3 millimeters more than their original disc height, I think that itself acts as sufficient enough decompression and stabilization for these patients who have only dynamic symptoms. So, and this has been proven, and even follow-up studies, like you do a severe lumbar canal stenosis, immediate post-operatively the canal is still narrow. It means you do a post-op MRI after an OLIF, the canal is still narrow, but you wait for 1 year, you do an MRI, you would see that the ligament has thinned out, the disc has withdrawn and the canal has opened up. The facets also have regressed. So all these changes, the canal remodeling happens over a period of time. But if the patient has rest symptoms, and it is very important that in lumbar canal stenosis, if the patient has a rest symptom, always you need to add a direct decompression. Always. Means that is the general rule. There are exceptions to that. But I think whenever there is a rest symptom, you should always add a direct decompression. Now the other common area where it is used is an adjacent segment disease. A non-lordotic fusion, as you say, performed several years ago, and now the patient has come with an adjacent level hyperlordosis and retrolisthesis, which is what commonly happens after these non-lordotic fusions. And again, these things are used or can be adequately treated by doing using a hyperlordotic cage with the OLIF. Like these are all 15 degree, 18 degree cages, which can be used, and then you can stabilize from the lateral point itself. The other thing is, one of the best indications for OLIF or retroperitoneal approaches, as I was mentioning, is degenerative scoliosis. Now in degen scoli, if you have to do this with a posterior approach, the amount of muscle dissection is more. And if you are doing a multi-level MIS TLIF, you are basically repeating the same procedure at multiple levels over and over again. What you do at L23, you have to come back and do it at L34. You come back and do it at L45. Whereas in an OLIF, you are already on the retroperitoneum. You have already identified the anterior border of the psoas. All you need to do is go along the anterior border of the psoas, go from one disc to the next disc to the next disc. And it is so easy that within 20 to 30 minutes you can finish 111 level when you are doing a retroperitoneal approach, and that is the basic advantage. It is quick, it is fast, it is the blood loss is hardly anything, there is no muscle dissection, and it is, you can actually, just by putting multiple cages at all these levels, you can achieve a good amount of correction, as you can see there in these cases. Even in more difficult cases you can do. Degens Kohli, again, there is a MISDEF classification. I think you all know that. So usually MISDEF 1 and 2 are considered ideal for OLIF. MISDEF 1 is actually only decompression. MISDEF 2s are the ones that are ideal for OLIF. In 3, usually these are used in conjunction with a posterior decompression procedure as well, posterior release and a lordosis restoration. So that is something that we have to take a note. Again, OLIF is used in pseudoarthrosis after failed posterolateral fusion. You can go anterior, put in a cage. You can use it in infection. Tuberculosis we have used it in pyogenic infection. Post-operative instability. Once the infection is cured, if the patient still has post-operative instability, you can go and stabilize, because you can put a large cage. We have done corpectomies. We have actually published that also. From a lateral retroperitoneal approach, you can do a corpectomy in cases where there is a tumor or trauma or any kind of an infective process. Discogenic pain necessitating surgery, I usually do not operate for these cases, but again, it is probably worthwhile to consider OLIF where you can preserve all the elements of the spine, rather than trying for a posterior approach where you are resecting some of the elements where there is hardly any pathology. But once we identify these cases, we need to go through a certain set of preoperative planning. And this is something that is very, very important as we start out doing these kind of surgeries. The most important and the first thing that we all neglect, we all come for courses, we all do this, we learn, and then we go back and we see we don't have anything to do OLIF in our OT. The first thing that you need to get is your infrastructure. You need to have long instruments. Your access, your retractor blades are anywhere between 9 to 15 centimeters long. You need to have instruments that are going to reach to that area. And I'm not talking about the instruments that the company person is going to bring. They will bring the long instruments, but you need to have a bipolar which is going to reach there, so that if you have a segmental vessel injury, you can control it. You need to have a bayonet forceps which is long enough to reach there. You need to have a scissor which is long enough to reach there. So all these general instruments you need to have. You need to keep it ready before you start doing your, this one. Of course, retractor nowadays, the access instruments, that is the retractor system that is there. Usually, again, in the first few cases, the companies will do, but I prefer to have my own retractor system. So that we are not dependent on a set that has to come to the OT for us to do the surgery, and we cannot be dependent on any particular type of implant. The other thing is why we are all here, to get a detailed knowledge about what are the structures that are there en route, how to prevent complications, how to select your cases, all those things. And you can do cadaver programs, VSPs, in your first cases, you can actually call a proctor to be on standby when you are doing these cases. So these are the ways in which you can minimize the hurdles, minimize the complications in your initial few cases. When you go back, you start doing your OLIF case, the first 2 cases you have a problem, I am not so sure you will attempt the third case. So it is very, very important to select these first cases in the right way and to do them in the right way, so that you can actually, get convinced that this is a procedure that you can adapt into your day-to-day practice. But again, looking for that ideal case, some people wait for 3 months, some people wait for 4 months, 6 months. And by the time the ideal case comes, you would have forgotten what you have learned in the course. Again, it is not ideal to wait too long. So it's better, to select the appropriate case as early as possible. And of course, once you have seen the case, once you see that, okay, this is something that I could consider for OLIF, you need to start planning for the execution part. That is how you are going to do. What are the factors that you will take into consideration when you have to select a case for OLIF? And I usually divide them into these 3 categories. The first thing is suitability of approach, whether you can do OLIF, whether it is possible to do OLIF. The second is, this is mechanism of indirect decompression. That is, you are actually distracting your disc space. So the second pathology is whether you are actually able to distract the disc space. Is the segment mobile enough to be distracted by your OLIF approach? Is it distractible or not? The third is you may be able to distract it, but is that distraction treating the pathology? Like if there is a listhesis, whether it is going to go back? Is there a compression, whether it is going to get relieved by the decompression, by the distraction, disc space distraction? These are the factors that you can consider, and of course pathology, complex pathology. Let us consider one by one. Suitability of approach, you need to consider iliac cleft, especially we used to consider that a lot when we are doing XLIF or direct lateral approaches. For OLIF, it is not so much of a concern. Vascular anatomy, I think Dr. Surya has beautifully covered. Anything that is more than 1 centimeter gap between the lateral border of the vessel as well as the anterior border of the psoas is good enough for OLIF. Anything that is more than 1 centimeter, but nowadays we have done it even in smaller corridors, especially because when you make the patient, there has already been an MR anatomical study where you do an MRI in the supine position, you do an MRI in the right lateral position. There is the gap actually increases because your vessels all fall forward, whereas the psoas stays there. Psoas doesn't fall. So the vessels all fall forward a little bit, a few millimeters at least, with the retroperitoneal structures. And that itself is increasing the corridor to an extent where you can easily get the corridor sufficient enough to do your OLIF. Of course, previous retroperitoneal surgery you should always avoid. So these are again, already he has shown the images. This is standard. Now you have something called as Mickey Mouse sign. I think it's hidden by my face there. You have these panda ears and rabbit ears. So different names are there, rising psoas signs and all those things. And whenever you see this, you start from next time onwards, you start looking at your MRIs. Nowadays, we always look at this corridor. Irrespective of whether we are going to do OLIF or not, it's become a habit now that we look at the corridor, whether this corridor is suitable. And imagine all these three are at L4-5 only. They are not at different levels. So the configuration of the vessels as well as the psoas can vary significantly. And again, this is what I showed. The corridor increases in the lateral position, and even if this much corridor is available now, I think you will be able to go ahead and do an OLIF, but not in your initial few cases, but over a period of time. And that is one of the reasons why even Dr. Surya was mentioning that, it is always, it's done from the left side. This is one of the reasons, because the right side, you may think that you may have the same corridor, but you see here, it is the aorta or the iliac artery. And these are thick-walled vessels. Whereas the same thing you do from the right side, either it is the, it's usually the vena cava or the vein. And these are thin-walled vessels. So the chances of injury are significantly higher. So that is why, even though there is a good window, you should be very, very careful if you are doing this from the right side. And of course, if you are doing from the right side, it is always worthwhile to go through the psoas than come anterior to the psoas. If you are doing from the right side, I think that is something that we need to understand. You need to look for any variations in the anatomy. You can see this coming in. You may see that there is a good window here, but you see there is an abnormal vessel. So that is there. So no, so all these things you need to take care. The other thing that you need to also consider is the proximity of the contralateral iliac vein, common iliac vein, to the anterolateral aspect of the contralateral disc, because you are going to come from here and you are putting your cage. You see, this is the cage there. You see how close the cage is to the contralateral vessel, and that is something that you need to again notice when you are doing your thing. Of course, segmental vessels are usually not a problem. They lie in the middle of the disc space, and only the pin that can sometimes injure. Ureter and retroperitoneal fat, usually, you can make out in your MRI itself in the ureter. And this is what I was telling. Sometimes it is so superficial that you will be able to visualize the ureter and its peristalsis. It's hardly any fascia left there, even though you are in the correct plane. And that is something that you need to identify. There is in 16% it is estimated that there is a potential risk of injury to the ureter. You just need to retract it on anterior and then go to the anterior border of the psoas. That is the psoas muscle that is there. So that is something you need to do. Retroperitoneal fat, in especially thin patients, you are coming from an oblique approach, you are coming from anterior. So in all these MRIs, you need to visualize how close or where is the retroperitoneal fat ending, because in this patient, if you come from a very oblique approach, you see you are directly going into the peritoneum. You are not even, there is no retroperitoneal, where the transversalis fascia and the parietal peritoneum have already fused. There is hardly any gap between those two. So this is something that you always need to consider in these cases. And this is the lateroconal fascia that I was telling, and it joins with a colon from around the descending fascia from around the descending colon to form what is called as the fusion fascia. And this is the space that you need to see. You need to go into this space, and then you need to come here. So again, if you enter this space here, if you breach this fascia and you go into this space, there is a potential of identifying the the ureter and directly going into the anterior vertebral space. So you need to be on the psoas and make the psoas bare and retract the fascia from the psoas till you reach that space. So that is something that we need to take care in all these cases. The second thing, one is suitability of approach. These are the factors that you need to consider. The second is how good can you achieve this indirect decompression. That is, the first thing that you need to see is the mobility or flexibility of the segment. Now, in case if there is a chronically collapsed disc space, there is an anterior osteophyte, posterior osteophyte, facet is fused, you are not able to going to distract that. You can't put a cage in to distract that segment, right? So you need to be very, very careful in all these cases where there is an ALL shortening. You see all these things where there is a bridging facetal fusion, all these type of cases where the distraction is something that is not going to reduce the listhesis. If this kind of a curved facet is there, and you are trying to distract that segment to reduce the listhesis, this is not going to move back, because that superior articular process is always going to restrict the IAP from moving back, which is required for a reduction of listhesis. So all these factors you need to consider when you are doing that. Again, these things that I mentioned, chronically collapsed disc space, facetal arthrosis, you see facetal fusions some places, anterior bridging osteophytes. Most of these cases, there are ways in which we can identify whether they are flexible or not, and I'll tell that in a short while. And this is the one. So usually what we do in these cases is what is called as a supine extension X-ray or a full extension lateral view, where you place a block below the hip. Usually we place it a little more down, and in order to make the spine hyperextend while the patient is in the supine position, and that actually shows us how much the ALL is distractible, how much the segment is distractible. And if the segment is not moving at all in this with this, then obviously these are fused, and usually it will require a direct release either from posterior or a multiple combined anterior and posterior approach in order to restore lordosis while doing decompression in these particular cases. So that is something that you need to understand. And you see, this is a standing extension X-ray of this patient, one of our patients, so very obese lady who had a multi-level listhesis. This is standing extension, and you can see full extension lateral view, everything has come back into place. So this is the amount of correction that can happen in these X-rays, and you can just go ahead and do an OLIF at multi-level for these particular cases. The third thing is you may be able to distract the segment, but it is not going to treat the pathology. So, and these are the factors. There is a medial facetal hypertrophy. You see these things. Whenever there is a medial facetal hypertrophy, the medial lip of the superior articular process impinges on the traversing nerve root, right? So in those cases, even if you distract, the distraction is happening for the upper vertebral body. This medial superior articular process slip is on the inferior vertebral body, and that is going to continue to compress on the traversing nerve root. So that is something again that you need to take care in these cases. Front back foraminal stenosis is again, these are not going to be treated. An up down foraminal stenosis, by distracting, you are able to distract the segment and widen the foraminal dimension. That is going to get treated. Whereas if there is a superior articular process, an osteophyte that is impinging on the nerve root, again by distracting, you're not going to get that corrected, and that is something that again you need to see. Severe central canal stenosis, as I earlier mentioned, in the presence of rest symptoms, usually it should not be done. Radicular pain at rest, again similar thing. But there are some cases where you know that okay, we distract, you reduce the listhesis, that compression that is there on the patient, on the nerve, which is producing the radicular pain, is going to go away, and that itself is sufficient to relieve the radicular pain at rest. So that in those cases you can still opt for that. We have done simultaneous endoscopic approaches from an anterior. Through an OLIF approach itself, you put in an endoscope and remove the fragment. Basically, instead of doing a transforaminal approach from behind, you have done a transforaminal approach from back. All those things, modifications you can do. I'm not going to discuss about all those things. And the complex pathologies, this is definitely no in the early cases, as I told, grade 3 listhesis, severe scoliosis where COB is more than 40, lateral listhesis more than 10, and of course, above L1. OLIF can also be done in cases above L1, and that is also something that you need to take care. You need to do all these investigations. You need to do x-rays. I'm sure all of you know standing, flexion, extension. We also need to do a whole spine standing, and you need to measure these parameters to classify what kind of a deformity you are dealing with, whether it is just a regional deformity or you are looking at something that is global, or extending beyond the segments that you are planning to treat. You need to do an MRI for all the reasons that we have told right now, and this is something that we have always inculcated in all our MRIs that are done for lumbar spine. For any pathology, there is now one sequence that is involved for this one. It helps us to, first of all, if you are doing an anterior approach, it helps us to identify the abdominal structures, and also if we are doing a transforaminal approach also, it helps us to identify or plan our trajectory. Means transforaminal endoscopic approach. Also, it helps us to plan our trajectory based on the pathology that is there. So this is something that has become a routine in our centers, and I think that is a good thing to inculcate everywhere. CT abdomen, usually we don't get it done at all, and and as the study also showed, it's probably avoidable, especially if you are doing an O-arm intraoperatively. It just increases the radiation exposure before you take the patient into the operation room. MR neurographies have been done basically in the era of trans-psoas approaches to identify the location of the lumbar plexus within the psoas muscle, to identify the exact location. But again, for OLIF, it doesn't, is not routinely makes sense. So you need to consider all these things. To summarize, it is very easy to remember. One, whether it is possible, whether the approach is possible, whether the structures will allow you to do a OLIF approach. Two, whether you can distract, whether it is possible to distract, whether the distraction is going to be helpful. 3, and whether the pathology is going to allow you to do this. So these are the factors that you need to consider, whether it is possible, whether it is feasible, or whether it is effective. Okay, so these are the 3 things that you need to consider when planning for OLIF. Now coming to the actual technique, nowadays most of our OLIF, especially if it is anything under 3 levels, only if it is more than 3 levels, we usually do a 2-stage approach. That is, we do a OLIF in the lateral position, flip the patient prone, and then put percutaneous screws. But anything less than that, usually 2 levels and all, it's all done in a single stage lateral position. You put the screws in the lateral position itself, and that is what I'm going to show. And obviously we started doing this when we did not have 3D navigation, but nowadays it is quite easy or quite efficiently done with 3D navigation itself. And this is the difference in the position that I was always telling. I was earlier telling this is how we used to position for a D-lift approach, and this is how we are positioning. And you can see those days we had the old table, no navigation, and now we have this Allen table and all the navigation and all those things. So it makes the job much more easier. The standard incision is usually around 5 to 8 centimeters from the center of the disc. Now, why we say 5 to 8 centimeters is you should always take into consideration the anatomy of the psoas. So if the psoas is a flat, it is not going beyond the anterior border of the vertebral body. You don't have to go very anterior to the anterior border of the vertebral body. You can put your incision right there and you can enter, because your psoas is going to allow you to do that. But if the psoas is a little more bulky, if the psoas is bulging beyond the anterior border of the vertebral body, then probably you need to go a little more anterior. You need to come from a little more oblique trajectory in order to bypass that anterior border of the psoas and get that access there in those cases. So usually around 5 to 8 centimeters from the center of the disc, in the same line as the disc. If you are doing a multi-level approach, the incision will come on the vertebral body in the between the two discs. If you are doing 3-level, usually the incision will be again centered over the middle disc which you are doing. More than 4 levels, maybe sometimes you have to use 2 incisions. So that is why it is. The first step, again, as I told, this is the approach that we need to get. Now, this is one maneuver that we need to understand, orthogonal maneuver. So we are coming from an oblique direction like this, right? What will happen if you go in the same trajectory all the way to the contralateral side? You are going into the contralateral foramina, isn't it? So, and that is going to injure your contralateral exiting nerve root. But you don't want the cage to be positioned like that. You want the cage to be positioned horizontally across the disc space. So what you need to do is you need to do an orthogonal maneuver. That means as you are entering the disc space, you need to move your hand forward so that it becomes perpendicular to the floor. So as you see, you are entering oblique. The moment you enter, you are changing the direction. So this is called an orthogonal maneuver, and this is one of the most important steps that you need to learn while doing an OLIF approach. You go in oblique, and then as you are going into the disc space, you make it straight so that you become perpendicular to the floor. So that is orthogonal maneuver that you need to do. Sorry. And this orthogonal maneuver you will have to do at every step of the surgery, not just while doing your cage placement. While doing your disc preparation also, you need to do that. While preparing the end plates, while doing your trialing, while doing this, while removing the disc, every instrument that goes into the disc space cannot go in straight. It has to go in and then turn. So this maneuver has to be performed at each and every step of OLIF. The second important thing that you need to do is a contralateral annular release. You are distracting the disc space, right? Now effectively distraction happens because most of the times you see in these cases there are lateral osteophytes, especially in degen scoliosis. So unless you distract the contralateral annulus, you will not be able to create a uniform distraction. If you keep the contralateral annulus intact, you select a bigger cage, the disc space will become like this. Okay, so if you distract that, then there will be uniform. If you release the contralateral annulus, then it will become a uniform disc space distraction. So that is something that you always have to do, contralateral annular release. And then you do the trialing, select your appropriate size, and then put in your cage, and then put in your posterior fixation. So this is the case that I was telling about. I have already shown these images, the X-ray. So this is the video. So this is not just for this case. This video is actually compiled from many cases to show all the structures that we can encounter en route. So this is the first step that we do. It's not necessary. O-arm is not absolutely necessary. So the first thing that we do is again mark these, put off the guide wires from posterior into all the 4 pedicles. Now usually we can do simultaneously. While one person is doing from posterior, we can always start from anterior. As you see there, we are already marking the skin. If not, you need to use the C-arm to see around 5 to 8 centimeters that I showed anterior to the disc space. And once that is done, you start your exposure. So that is the incision. This is the external oblique fascia. The fascia of the external oblique is the only structure that you actually need to sharply divide, because that is the tough structure. You can't just penetrate through that. So that is the only thing that you need to use scissor of. After the skin, the only use scissor or a monopolar in order to remove the fascia of the external oblique. And once the external oblique is split, the muscles of the external oblique, internal oblique and transversus are split in the direction, and then use a retraction to retract that. So that is the transversalis that is getting split. And once the transversalis is split, you see the transversus fascia. So that yellow glistening fat has to be seen. Otherwise, you are not in the retroperitoneal space. Until you see that yellow glistening fat, you don't put your finger inside and start dissecting that. So again, you can see these structures en route as you are doing that. So the first thing that you do need to do is, we are going to show that on the cadaver, the direction is not like this. Your finger direction is, because you are retracting the retroperitoneum anteriorly, you don't go in like this. The first step is go backwards. Go palpate the posterior abdominal wall, release the retroperitoneal structures across at least 4 to 5 centimeters. Even if you're doing one level, you need to sweep your fingers across superior-inferiorly as we are going deeper to release the retroperitoneal structure, so that they will automatically fall forwards. You don't have to do much. Once you release them from the posterior abdominal wall, all the structures are going to fall forward themselves. So once that is done, you identify the anterior border of the psoas, and that is the genitofemoral nerve. So usually the genitofemoral nerve is on the surface of the psoas muscle, especially at L3-4 and very rarely at L4-5. So you need to visualize, in case if it is seen also, you don't have to touch that. You don't have to go anywhere near that. You just go anterior to that and retract the psoas muscle anteriorly. Again, you need to have a long root retractor to do that, which we again got it made after we started doing these cases. So this is what again Dr. Surya was mentioning, ascending lumbar vein. Many people do OLIF without microscope. They just go in and do. It is possible as long as you don't encounter any anomalies, it is perfectly fine. But sometimes using a microscope helps us to visualize these structures. And unlike what Dr. Surya told, we need to preserve it. It is not that necessary. You can just transect an ascending lumbar vein. It's not that an important vein. Now, anterior tendon fibers. You see that this can be sometimes be confusing with a genitofemoral nerve. Sometimes you may think that this is genitofemoral nerve, but it actually not. These are just the anterior fibers of the psoas tendon, and that is another sure shot method or another sure shot anatomical landmark to say that you are right on the anterior border of the psoas. If you have seen the anterior tendon of either psoas major or psoas minor, you clearly know that you are in the anterior border of the this one. And once that is done, you do your dilatation. You put your dilator there to see whether you are in the right place. Either you have navigation, or you put your dilator and check with the CM whether you are in the right place, right direction. And once that is done, you anchor. So you don't leave your dilator floating around in the abdominal wall, because it is just going to slip. There is nothing holding the dilator there. Your tissues, unlike your posterior muscles, the dilator is not going to stay in that place. It's just going to float, and it's just going to fall into the anterior abdominal area. So you anchor it, put it all the way into the disc space as we are doing here. And then over that, you do a sequential dilatation, identify the length of retractor that is required, and then you put your retractor. Once the retractor is put, then you can do your, usually there will be a small area of muscle that is there. You can either dissect them using a peanut, or you can use a monopolar to dissect that, identify the disc space, see the extent of annulotomy that is required, either again with navigation or with a C-arm guidance, and then start removing the disc. As you see now, we are removing the end plate. Usually I try to remove that in bulk. If you want, I can just replay that. I just made it fast. So you see, again, you see the orthogonal maneuver. The moment you go inside, you are in the deeper into the disc space. You see our disc forceps is turning. So, and then you can remove an entire end plate by just removing it, just like you do in ACDF procedure, anterior cervical approach. You do your end plate preparation in the right direction. Make sure that you are in the right direction. Again, that is one more point that I want to tell you to be careful. You can see your dilatation, how it is going, your distraction, and you see how close you are to the contralateral annulus. And that is why you need to be careful that there are no vessels there. Because if you break your contralateral annulus very close to the contralateral common iliac vein, sometimes your corpse can go and injure the contralateral vein. So that is something again that you have to be very careful. So once that is done, again, you break your contralateral annulus. All these things nowadays we do under means navigation. We don't take C-arms. Everything, including the direction, the trajectory, the extent of end plate preparation. Of course, adequacy is something that we have to check during that. Bone graft is something that we have to be very careful in OLIF. We don't have a graft anywhere. People have tried to take it from the iliac crest, and that has resulted, because the amount of graft that is required to fill this large cage is huge, and you can't, means it's not ideal according to me, to remove that much of a bone from a iliac crest. So usually what we use is either bone substitutes. Earlier we used to use, but nowadays we get this allograft from our bone bank and we mix it with the patient's marrow blood. While we are fixing the percutaneous reference frame for the navigation into the PSIS, so we just aspirate the marrow blood from the PSIS before we fix the frame, and then we mix the allograft, that is the graft that we have obtained from the bone bank, with the patient's marrow blood, and then we put it, fill it into the cage. And so that is what is done. Again, during cage placement also, you need to make sure that you are in the correct orthogonal manner, as you are seeing in the inset there, and you can see that, see the extent of your cage placement. So that is how it is, and once you remove that, you will see the good plane between the psoas and the retroperitoneum. There is no hemostasis to be achieved. There is hardly anything that you need to do, and it is quite simple. And after that, you come back and you do a percutaneous pedicle screw fixation after you have put the cage. So this is the effect that we can achieve. Even in tough cases, even in collapsed disc spaces like this, you can actually do this much of a distraction. The amount of distraction that you can do with a lateral approach is nowhere comparable to what you can achieve with a posterior approach. It is like quite a good amount of distraction that you are able to achieve. And you see, again, in these cases, we have not done any facetectomy, no release, not use the screws to pull back the bone. By just putting a cage, this entire thing reduces. Even in tough cases like this, you see hardly there is any bone gap between these bones there. Again, but you see, you always look at the difference between a supine MRI and a standing X-ray. You can see there is a good amount of disc preserved here, but hardly any disc seen there. So that means that it's a very grossly unstable segment. Again, as I told, usually in these cases, we do this full extension lateral view. This is standing X-ray and this is supine extension X-ray. You see the amount of reduction that happens just by positioning. And in these cases, you can actually go ahead and do an OLIF single stage. As I was mentioning, OLIF is very, very ideal for these gross degenerative scoliosis patients. And this much of correction can be achieved by just placing cages at 3 levels. This is a 3-level OLIF and a 5-level fixation, like as you are seeing there. And no bone removal, no direct decompression, no intracanal approach. So that is the good thing about all these things. A good amount of decompression and reduction can be achieved using these techniques. Again, in these cases with thoracic kyphosis, which is more than around 50, usually in these cases, again, if you see conventional idea, we have to go to the thoracic spine in order to correct these kind of approaches. But again, we resort to do a simple 3-level OLIF. You see the amount of correction that we can achieve by just doing a 3-level OLIF in these particular cases. We need to identify the type of abnormality that we are dealing with. Severe instability. Again, you see the amount of restoration of the kyphosis that happens in a full extension view. And again, in these cases, it is important to see the type of the collapse. Here it's a lateral vertebral wedging, and this disc is not like a symmetric disc space, so you can't use a regular cage. You can see the type of disc that is there. So usually we have a coronally wedged cages also that are available. I don't know if they are there today, so we can show it to you. The cage itself comes with a shape like this. So these are useful for cases where there is already some significant amount of vertebral wedging that are there. And by using these kind of cages, you can see the amount of decompression as well as restoration of pelvic parameters that we can achieve for these cases. Now, when we are doing this in L2 to L5, why not at L5S1? Now in L5S1, again, you see these cases, grade 2 listhesis, hardly any lordosis that is there, and a good amount of lordosis that can be achieved with just an anterior approach in these cases. And as you can see there, I think yesterday you have all seen the importance of anterior approach, and I am not going into too much of details about how good it is at restoring lordosis as compared to MIST lift. So MIST lift is not bad, and there are techniques that you use in MIST lift to preserve or restore lordosis, and but it is much more easier and much more efficacious when you do with an anterior approach as compared to a posterior approach. Now this is a brief about L5S1 oblique corridor, you know. So this is the corridor that we use. Unlike in L2 to L5, where you come lateral to the vessels, and between the anterior border of the psoas and the border of the lateral border of the vessels, you come lateral to the vessels. Whereas in an L5S1, there is no space lateral to the vessels. They are already bifurcated and they are already going laterally. So you come in between the vessels. So this is more like a lateral A-lift. Some people call it a lateral A-lift, while what you saw yesterday was a supine A-lift. Means you do the A-lift in a supine position. Here you are putting the same thing, you are doing the same A-lift procedure in the lateral position. So that is why it is called as a lateral A-lift or an O-lift L5S1. So that is what is the approach that is entailed. So you can see the amount of disc preparation. I have a small video. So again, it is quite simple. Sorry. So again, it is quite simple. So as you go more oblique, I'll show the incision marking on the cadaver because I don't have the video for that. So that's a very long video that I have. So your incision marking comes more anterior because you need to be more anterior. That is, you need to go between the vessels. So in an O-lift, your incision comes probably somewhere on the anterior axillary line downwards like this. Whereas in an A-lift for a lateral L or an O-lift 5-1 or a lateral A-lift, your incision comes more inferior and more anterior. So, and usually you use CAM parameters or, as I said, navigation parameters in order to identify the correct incision site. So, yeah. So once that is done, again, you usually when you come more anterior, you don't have many muscles there because you just have tendinous insertions. So you just open the aponeurosis of the external oblique, internal oblique. Usually they fuse to form a single aponeurosis, and once you open that, you are already in the retroperitoneal space. And once in the retroperitoneal space, the same thing. Again, you sweep, identify the iliac crest inferiorly, and then you sweep the retroperitoneal structures anterior, and then you directly go. You can put your finger and identify the pulsation. I think that is the first thing that you need to do. And once you see the pulsation, that is where you know that the iliac vessels are there. And then you start dissecting. Very little of cautery you should use. Just dissect. The vein sometimes can be very, the anatomy can be varying. You need to observe preoperatively. I think yesterday also it was discussed about May-Thurner's and what are the parameters that you need to see in all these cases. So you need to identify the vein, make sure that it is not adherent or make sure it is not stuck to the structures underneath, and then retract it so that you are not causing injury. Then identify the anterior border of the disc space. Just use blunt dissection and retract the disc space all the way anterior. So I think this is something that you saw yesterday. It is almost quite similar, but the patient is in the lateral position. That is the only difference. And once you do that, you see the median sacral vessels coagulate and cut. Here you are more lateral than in A-lift, where you are more anterior approach. So you may need to reposition the retractor, and that is the vein that is at the superior bifurcation. So usually what we do is you just put a small abgel and then put a bifurcation retractor. There is a third retractor that comes. This is a bifurcation retractor, and you can put that. And once you do that, you have an access to the disc. Now here you need to do something called as a reverse orthogonal maneuver, because you are going in obliquely, but you need to go in only 2 to 5. What you did like this, whereas here you are doing like this, because you need to go more into the disc space more towards the posterior. And as you can see, my instruments are going below here, and you are removing more and more disc from under the the superior blade, because that is where your anterior approach, because you are again seeing it from an oblique position. Now this is again, I was mentioning that this is an indigenously developed cage that we are yet to release into the market. So this is an oblique hold. You just goes in like that, you just hammer it into place, and there are 2 screws to hold this cage in place. And once that is done, you put a locking screw, and that is the vein. And again, as you can see, there is hardly any bleeding. So usually if you select your cases wisely, if you are careful during this, there is hardly any chance of vascular injury even in these cases. Now, when you have to do multi-level, your incision may come a little more oblique. Means you may have to take one single incision for both L4-5 and L5-S1. So that is what is the bifurcation of the common iliac artery into the internal and external iliac, and then you retract them. Sometimes usually the vein may be buried inside, which is lucky for you, or you need to identify the vein where it is coming under this. You open a fascia, identify the anterior border of the disc space, and then start widening that area in a blunt manner. Usually you should, because of the hypogastric plexus, you should not be doing too much of a cauterization in that area. I think yesterday it was discussed, the heart of the hypogastric plexus lies at the bifurcation of the common iliac vein. So that is where the superior, and that area is something that you should be very careful. So you need to be, again, disc space preparation. Similarly, you prepare the disc space adequately, and then identify the extent of your disc space preparation either with navigation or with C-arm, and then put in your cage, and then put in your screw. And once that is done, now you have to go to L4-5, right? All you have to do is just jump on those vessels. Once that is done, you can just go superior to the vessels, and you see that is the psoas muscle, and just dissect a little bit there, that is your L4-5. So you just jump on the vessels, and there you have the L4-5 disc, and it is quite easy to do that. Once you have done L5-S1, it is quite. So this is what I was telling. This is the sympathetic chain, and that is the small branch that goes anterior, and then you can just retract the sympathetic chain anteriorly. Were you able to appreciate that? I can rewind it a little if you want. So that is the sympathetic chain. All that sympathetic chain. So one branch goes anterior. You just cut that branch, and then you can retract the entire chain anterior. You don't have to sacrifice the whole chain. So once that is done, then you can do your approach, orthogonal maneuver, reverse orthogonal maneuver, as you are telling. Now usually this happens as a single stage lateral position, where you can do it simultaneously. Even multi-level cases also you can do with these approaches. So I think this is the basic talk, basic things that we need to know. The routine standard technique, standard indications, standard preoperative planning, and standard technique that we need to see. I think that should be enough for today, rather than going into troubleshooting, complications, and complicated cases and all those things, isn't it? Yeah. Any questions are there from your side? Yes.
In the presentation, we saw that the position of the patient in lateral position, and the legs were kept extended, hip also was extended. So is it recommended that we flex the hip to relax the psoas so that retraction becomes easier?
Why? So if you see in when we are doing XLIF, when we are doing the trans psoas approaches, the upper limb was flexed. Now you are breaking the table, you are stretching the psoas muscle, and that is why you had to flex the upper limb, the non-dependent leg, to relax the psoas muscle a little bit. That was the whole idea. Now in Olive, you are not breaking the table, so you don't have to flex the leg. That is one concept. The second concept is you want the psoas to be posterior. You flex your leg, the psoas becomes more bulky. It relaxes. It becomes bulky and it restricts your view. You extend it, the psoas tautens, and then it moves posterior. It increases your window. So you need to keep your leg straight.
So one more question that in indications we saw infective case like port spine also. So in such cases, do we have enough bone stock to place our cage? Because of
You
sometimes
need to select your cases accordingly. And as I told, you have cages here that are around 18 millimeters height, which are there. And that is when I mentioned that we can even do a corpectomy. You can even put a lateral corpectomy cage in case if the bone stock is not good. From a lateral approach, it is much more easier, and especially in cases where your pedicles are intact. Usually in infection that is spondylodiscitis, which is predominantly involving the paradiscal spaces, you have the pedicle intact and the posterior vertebral border is relatively more preserved than the anterior part. So you have to remove the posterior part of the vertebral body, which is still preserved, in order to go anterior if you come from plan to do a posterolateral corpectomy, which can be avoided in a lateral approach.
and so like one more last question, like suppose when we start doing, we are doing L4-5 as a routine our first. So like what should be the window period when we start attempting L5S1 also? Because yesterday we saw that there might be some adhesions with the left common iliac when it is adhered with the ilio-lumbar vein. If something is there, we might have to abandon and come out and again. So how much should we do first?
Means for L5S1, even today, I always tell my vascular surgeon to be on standby, and they always come and they are there in the operation theater, and they always put their charges. I always tell that this is an insurance money, so that when actually I do have a problem, they are not. It's not like they are not there. They will come for one or two cases, and if they are not invested in the sense both, of course, I work in a private setup, invested in the sense of both finances as well as interest, they are not going to come for the third case. So they come, they put their charges as an access code. There is a nominal charge that is there, but they are there. But if they scrub in, they put their regular code. So they are always there for L5S1. Irrespective of how simple or how difficult it is, they are always there. I can show you examples where I have called in the vascular surgeon to scrub because the vessel was adherent that we were not able to retract it. And they have come and they have, retracted. We have used a rubber band loop to pull the entire vein backwards.
So how do we manage the post-op hip pain? Many times patient complaints of that pain in the thigh because of excess retract. So
see, again, I would like to quote my senior. What will you tell if the patient after TLIF complains of back pain?
Nothing much has surgeon point of view.
So this is a psoas. This is psoas pain. You have retracted the psoas, so you will have thigh pain.
Regarding the excess, suppose there is scoliosis towards the left side. I mean, concavity is towards the left side. Does it still make any?
So very wonderful question, sir. So usually, if it is convex to the right, both are issues. So I'll take a minute. So both are significant issues, convex to the right and convex to the left. How to plan surgically? Now, imagine that I'll take the simple one first. Simple one is where it is convex to the right. So you are approaching from a concave side, that is your left is concave. You may feel at the beginning of the surgery that with one single approach you can target all the disc spaces, right? But then you start doing it from either below or from above. Usually we start doing it from below, but now with navigation we have started doing it from above because your frame is started above. Again, that's a different question which I will answer. Now imagine that the ideal thing is to do it from below. You do it from below. The first cage you put, it corrects. The second cage you put, it corrects. The third cage you put, it corrects. By the time you are coming to that level, it has moved so much that you are no longer able to access it with the original incision that you have planned. That is not possible. So you may have to plan your incision, you may have to reconsider your incision in the middle of the surgery, especially if it is a severe scoliosis. Now, the second thing is your external and internal oblique muscles are diagonal, and those extend superior-inferiorly, whereas the transversus muscle is transversely oriented. You cannot retract the transversus muscle all the way from an L4-5 to an L1-2 or an L2-3. Means it is possible sometimes, but not always. It may not be easy. So usually what we have done in some cases is when we are doing multi-level, you have kept the superior oblique, inferior external and internal oblique incisions as the same. Means that is the same, but we have used a separate transversus incision lower down for an L3-4-4-5 and a separate transversus incision above for an L1-2 or an L2-3. So that is something that we can change. That is the second option. That is the second thing. Now, in a convex side approach, if you are approaching from the convex side, in the beginning, you may feel that your incisions are so wide apart. But the moment you put 2 cages below, your spine corrects and you feel that the upper level is now relatively more easily accessible than what you originally thought was. What L1-2 approach was originally going through the rib now has come into play. Now it has corrected a little so that now you are able to approach it below the rib itself. But many times L1-2 you may have to sacrifice the 12th rib, especially if it is a longer rib. The third thing is in a multi-level case, whether you should come from top down or down up. That is again a very challenging question, because now we use navigation and our navigation is fixed to the PSIs. And irrespective of the curvature, whether it is right convex or left convex, imagine that you start from above. You start at L1-2, L2-3, L3-4, L4-5 and L5-S1, or you start L2-3. So when you do L2-3, your 3-4-4-5 configuration with relation to the frame is still intact. So you can use still navigation. That navigation accuracy is still preserved. Your rotation has not changed. So all those things make a lot of difference. It makes it easier, because if it is a rotated spine and you are, instead of entering in the right direction, if you are going more posterior or even more anterior, there is a chance of either a neural or a vascular injury. So that rotation helps, means navigation helps. So if you are doing from top down, you have the advantage that the navigation works. Without taking another image during the surgery, your navigation works at all the levels correctly. But the disadvantage is that what happens is you put L1-2, now L1-2 acts, or L2-3. L2-3 acts like a single block of bone. When you are distracting L3-4, you are distracting that whole segment, not just L2. There is no disc above that bone to cushion that distraction. When you put cages at L2-3, 3-4 and you are doing L4-5, you are now distracting the entire 3 bones. And especially in these patients, Degens coli, borderline osteoporosis, sometimes there is a high risk of end plate injury, end plate fracture, when you are trying to distract the L4-5 against already already block L2 to L4. That is like a single block. There is no disc in between. So that is the disadvantage. So what we have started doing is we first put off the guide wires at all these places and then still continue from below up, so that at least the distraction part is maintained, and we accept a certain level of inaccuracy on the navigation when we are doing a higher level.
Any more questions?
Trans psoas we have done, but only I know doctors who have done, surgeons who have done a right-sided approach, but again, as I said, initial stages definitely no, and you have to be extremely careful. And in case whenever there is a simple solution, whenever there is a bulky psoas, so bulky that you are not able to retract, you can go through the anterior fibers of the psoas. It's going through the anterior most few fibers of the psoas is not going to, uh, especially if it is a bulky psoas, and the muscle mass is so big, you can actually go through the anterior fibers of the psoas.
So even if there is a concavity towards the left side, so still approach, you can go from the left
It is
side.
OLIF
Because some
is a
people,
left-sided
yeah,
approach. Sir.
oh,
OLIF is always a
irrespective
left-sided.
of convexity
Yeah,
or
there is no
concavity.
other teaching to it. Means modifications are surgeon dependent.
Mhm.
But for teaching purposes, OLIF is always or only a left-sided approach.
Yes.
I request Deepak Aggarwal sir, the workshop director, to please felicitate Tomesh sir, who has taken pain, and I also request Dr. Rajendra sir to please join, who has taken a lot of effort. He has after observing camp yesterday. I think we can join for breakfast and then start with the demonstration.
10:30 will all come back here for demonstration.
हेलो 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 हेलो
हेलो।
हाँ
हाँ ठीक है,
ठीक है।
थोड़ी आवाज़ बढ़ा के रखियो।
हाँ वो मैं बढ़ा दूंगा अभी।
ठीक है, ओके। लो
नहीं सर का
बस बस
मेरा भी ऑन कर दो संचित
Yes, sir.
has everyone joined in the hall
Yeah, everybody is here.
are
Yeah.
you able to see the screen
Yeah.
X-ray
Yeah.
image
X-ray image. Yes.
give me the guide wire and give me a marker pen.
X-ray in inset and overhead camera main दिखा देना ठीक है
Give me a guide wire. Do you have a guide wire?
yes
इसमें मार्क आएगा? हाँ.
so you're connected
Okay. Hello. Who is there in the hall?
Yes, sir.
Anybody will coordinate?
Yes, sir. We can hear you.
Can you hear me?
Yes, sir.
Yeah. So okay. So as you can see, we can put some small drape here and here just to cover the cadaver. Put it till here. इधर तक ये बैंडेज है ना इधर तक Okay, so when we are starting to do with C-arm, are you able to see the patient, the cadaver as well as the C-arm image in the hall?
Yes, sir.
Shoot. 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 Shoot, please. Shoot. Are you able to see the patient and the C-arm? Shoot.
Yes, sir.
So what I'm trying to do is I'm trying to mark that L45. You know, as you can see, the patient already has a spondylolisthesis at L45. I think we'll use the same thing. So normally this is not required. We don't have to do this exercise. Shoot. No, but what I'm trying to do here is trying to give you a surface anatomy and an approach that is going to be easily targetable. Shoot. Sorry. Shoot. Okay. So this is L4 and this is L5. Now this is your surface anatomy according to the AP, according to the lateral image that we have taken. Now also we usually mark the iliac crest. If you see now, the iliac crest is going right across the L45 disc space, and that sometimes may interfere with our orthogonal maneuver, because if we have to put our cage inside, it may come close to the iliac crest. To the iliac crest may sometimes give a resistance to do an effective orthogonal maneuver. But I think this is okay. I think in this case it is not a major issue. Okay. So now what we are going to do is, as I told, we are around, we don't know the configuration of the psoas. Shoot. So that is the direction towards the disc space, right? So now this is the direction to the disc space. Because the iliac crest is there, we don't want our incision within 2 centimeters of the iliac crest because of the ilioinguinal and iliohypogastric nerve. So what I will do, because there is already a small opening here, I will make an incision anterior to that. Is that okay? Now people ask about horizontal incision, oblique incision, vertical incision. I always prefer to make an oblique incision like this, because number one, it's in the direction of the external oblique fibers. Number two, by any chance, if you want to extend the incision, you can just go like this, and it is oblique. It makes sense because as you go up, the psoas becomes thinner and thinner, and you are moving closer to the vertebral body. So that is why your obliquity decreases. You don't have to be as anterior for an upper lumbar level as much it is required for a lower lumbar level. Knife, please. Is that okay?
Yes, sir.
So I'll make the incision. Already there was an opening due to some prior procedure that has been done in this cadaver. So are you able to see the incision? Are you able to see the?
Vinay.
Yes, sir.
If not, I can do it under the microscope.
Right.
Anyways, so now once that is done, usually,
Yeah.
give me
Yeah.
knife. You see that small vessel there? Can you see that? Are you seeing the operative field?
Yes, sir.
Yeah, you can see that small vessel. So these are all cutaneous, this one, nerves and vessels, vascular bundle, which will be just above the external oblique. So sometimes you need to be careful, and if possible, you can preserve them. So now I have sharply incised the external oblique. As you are seeing the external oblique fascia, and as you are seeing there, these are the fibers of the external oblique muscle. Artery, please. Now marking this is going to give me a correct direction, because it is very easy to sway superiorly or inferiorly in this abdominal cavity. Artery, a longer one. I need a longer one. Yeah. So this is your, you see that now? External oblique. Are people in the hall able to appreciate?
Yes, sir.
So that is the external oblique. Okay. So you can just widen it with your fingers, and then you can appreciate the fibers of the internal oblique. Where is the camera? Oh, this one. Okay. So you can appreciate the direction of the fibers of the internal oblique, and again you split them in the direction of fibers. Are you seeing that? Okay.
Yes, sir.
So that is the internal oblique, and then once that is done, you have the transverses. You see how the direction changes? Can you see that?
Yes.
So that is the transversus muscle. Okay?
Yes.
And below that, what you are seeing is the transversalis fascia. So going through the layers of the abdomen is not a difficult thing at all. So I am just separating them because in a live tissue these facial planes are very loose, and the moment you open up a little you can actually see. Are you able to see?
Yes, yes, very clearly.
This is external, internal and transverse. So I have retracted all of them, and I have opened the transversalis fascia. Now you have to be very careful, just don't plunge into the transversalis fascia. Sometimes it is always better to lift it a little. Give me a scissor. Unless you are absolutely sure. And then once you lift that, you just make a cut. I told you, you have to see the glistening yellow fat, right?
Yes.
Until you see that, can you hold it please? Yeah. Until you see that, you don't go inside. And now you are able to see, appreciate. Can you see?
Yes, yes.
Okay.
Yes, we can see.
So that one. Now, first thing is what is the direction? You are able to see that fat there, right? Okay.
Yes.
So now hold this. You put your finger, first lift this and then sweep. Okay.
Right.
And then now I am separating them, and you see now I am palpating the iliac crest and then going posterior in the iliac crest and then going deeper. As I am going deeper, I am withdrawing this anterior. Now slowly I am able to retract it anterior. See, once you do that, give me a Langenbeck, a bigger one. Light inside, please. Yeah, yeah. Do you have a Divas? Give me a handheld retractor. वो एक handheld blade है ना? Yeah, I can use a microscope if you want. Table can leave. नहीं बस एक मिनट आने दो माइक्रोस्कोप. नहीं सीएम रहने दीजिए. वो नहीं सीएम रहने दीजिए. जस्ट ये कौन सा है? नहीं इधर नहीं आएगा. This will come in the way. नहीं this. टेबल पे थोड़ा मूव करो. टेबल भी थोड़ा टेबल इस तरह करो. आराम से धीरे धीरे. और माइक्रोस्कोप पीछे करो थोड़ा. हाँ टेबल और थोड़ा करो. बस ठीक. लाइट हम पोजीशन कर दो. मनोज ये ठीक है. इट्स ओके. ये टाइट यहाँ से होगा. I'll tighten it here once you are okay. एक मिनट. जो on microscope करता. Yeah. Is it okay, sir? Tight. Yeah. Tighten. Yeah, ये टाइट हो गया. बस ज़्यादा नहीं थोड़ा. ये बाहर से जो चेंज करते हैं फोकस कहाँ पे स्क्रीन. नहीं यहाँ. Can you please hold the
Sir, it is not focused.
Camera focus is working. Okay.
Now it is good, sir.
Yeah. So if you see now, just because we have separated, you see all the retroperitoneal structures have fallen forwards. Can you see? And that is the psoas muscle, right?
Yes, sir. Yes, sir.
Okay. So that is your psoas muscle. So this is inferior, this is superior. This is inferior, this is superior, this is posterior for the patient. This is anterior, where we are standing on the front of the patient. Give me a bayonet. So, or an artery, something. So normally the trick here is, in order to prevent any kind of a inadvertent thing, as soon as you are on the psoas, you try picking up all the facial layers and go in that plane. Can you see that? Are you able to see?
Yes, sir.
Okay. So once, because you should be seeing the fibers of the psoas like this, not like this, not like there is a fascia attached, but you see there?
Yes, sir.
So you should see the fibers of the psoas bare, and once that is done, then you are in the right plane. Okay?
Okay, sir.
So this is the stage where we usually put a long root retractor inside in order to retract the psoas muscle posteriorly. Now I can already see, no, that is the sympathetic chain. So the ureter will be here. I think it will be inside. No need to, usually if it is not seen, don't chase it. Okay?
Yes.
So most likely there, that one, see there?
Yes, sir.
Okay. So this looks like a ureter, most likely it will be there, but don't chase it. So if it is not seen, good for you. So once that is done, you start going backwards. Okay? You start moving the psoas back and push your abdominal or retroperitoneal contents anterior, and you can see that long structure there. That looks like some vessel, and now I am able to palpate the disc space. Now that is where you see, if you look at the drawing that we have made, you can see the anterior border of the body here and here. So that is the disc space, right? Right, this is the maximum zoom out. Okay. Anyway, so I can see that this is the vertebral border and my finger is pointing towards the disc, and so that will be the level of the disc, and I am able to actually palpate the disc there. Okay. Now, do you have a long root retractor or a handheld blade is there, or a devers? So normally we don't use this devers to retract the psoas, but now today I will make an exception. So you retracted the psoas, right? Okay, now the psoas is behind our blade. All right?
Sanchit, are you able to hear?
Yes, sir. Yes, sir.
And now, and if you are thinking, is it so easy in the live specimen also? It is. It is not at all a difficult approach, forceps. So once you remove the retroperitoneum and identify the anterior border of the psoas, it is very easy to go to the surface of the disc.
Sir,
Out
can you
of view,
move the camera a little bit up? We are not able to see it properly.
Now,
Yes, sir.
okay. So if you see, so that is the disc, right? Okay. You have mono?
Okay, sir.
It's okay. Give me the knife. So I will confirm with a C-arm, but because I have marked the surface marking and I am now pretty sure, I need a long blade. I am able to palpate the anterior border. See there? That is the anterior border. Can you make out? Of the vertebral body. Okay?
Okay.
Sanchit,
Yes, sir. Yes, sir.
please respond when sir asks. Are you
Okay,
able-
sir. Yeah.
Please.
Give me a scissor. So I will cut that vessel. Normally if there is a small vessel like that, you coagulate and then you can actually cut that. Okay, and that is your disc force, disc space.
Okay. Yeah.
Give me a peanut until then. Do you have the knife?
Sir, can I ask a question, please?
Yeah, sure.
Sir, do you recommend using bipolar to coagulate the anterior fibers of psoas so that the disc space can be still better seen?
Definitely yes, but I don't do it routinely.
Okay.
Only if your vision is hindered significantly and if there is any bleeding, only then we do that. We need small peanuts, chote.
And sir, whether we can use deburr for psoas retraction or anything?
We have a root retractor. You have a root retractor, no? The bayonet shaped root retractor. So we just use that. No, stop. Okay, enough. So you can just use a bayonet shaped root. No, don't retract so much. It's just gentle retraction. Yeah, just enough. Just hold it. Don't pull. Don't pull. No, don't. You are pulling. Leave. Just hold it. So that is the anterior border. The idea is to be at the junction of the anterior. Oh. Okay. I can operate from the next room. So I am making an incision in the disc. See there?
Yes.
Yes, sir.
Now, before I go too much inside, hold this. Give me the first dilator. As I told you, we anchor our first dilator into the disc space. Okay. Remove the beavers and C-arm. Microscope out. Are you able to see now? I have placed it at the.
Yes, sir.
Can you see that anterior border of the psoas?
Yes, sir.
The vessels are anterior over there. Okay.
Yes.
And I have made an incision which I presume is the anterior border. And if you see now, you see the disc line, right?
Yes, sir.
My the dilator is going towards that line. Okay.
Yeah.
So most likely that is the advantage of doing the marking. Microscope can be taken back a little. Mallet. No, why? No, it will come. See, mallet though. I have already put it. Now come up. Enough. So if you see from outside, can you see this from outside?
Sir, we can only see C-arm.
Okay, C-arm shoot, please. No. KV is too much. I think go back a little. All right?
Yes, sir.
No, no, I have already put it inside. I have already put it inside. So normally, I'll tell you. Okay. So this is where I have entered. Shoot. This is where I have entered. So I am palpating the discs now. I have pushed it inside. Shoot. Okay. Can you see here?
Yes, yes.
Now, as soon as you are going in, now I want to do this and I want to check our C-arm again. Shoot. You see that?
Not very clear.
KV, just increase the KV, go back, smooth the C-arm back a little. थोड़ा एंगल ऐसा कीजिए, उल्टा, बस उतना ज्यादा नहीं, थोड़ा, नहीं नहीं, कीजिए और एक बार, लुक्स ओके, थोड़ा एंगल थोड़ा ऐसा कीजिए. I'm just trying to get a true AP view. True lateral, sorry, ulta. Yeah, okay.
Yes.
Are you seeing that now?
Yes, sir.
All right.
Yes, sir.
So now I have put my first dilator, and if you see from above, from here, can you see? Yeah. You see the obliquity. You see this is the vertical plane, right?
Yes.
Yes, sir.
Okay. So this is the vertical plane. And now you see the obliquity with which we are coming. Now this is what we have to check, the orthogonal maneuver. All right.
Okay.
So from here to here, we should be able to do that. But before that, we will put our next dilators and prepare 130. थर्ड ये इसके बीच में और एक है. So normally there is nothing to dilate here. If you see, there is no muscle or anything. This is just to reach that appropriate diameter for us to put this one. And you see the length, it is around 110 दीजिए, 110. No, because it's here. No, slightly longer is better. No. So usually, if you are not able to do orthogonal maneuver because of a high iliac crest or because of a very bulky psoas muscle, and sometimes both in combination, and in those cases, you have an option of putting a shorter and an oblique cage. You may not be, because the more you try to do this orthogonal maneuver, you have to understand that your ilioinguinal and iliohypogastrics are somewhere there. There is a chance that they may be in another plane than the crest. They may be either superficial or deeper. But there is a chance that every time you are doing this, pushing this against the crest, you are crushing the nerve. So you need to be careful about that. What is it like this? Yes. Yeah. Okay. So there are different. Okay. So there are different. So there are different retractor systems in the market, and this is one what is called as a Mars 3 retractor, 3V, That is which is called 3 because it is a 3 blade system. All right. So now
sir.
in that each of the blade you give this opener. A opener. So if you see they are locked, can you see?
Yes, sir.
Yes, sir.
So now I can remove this. All right.
Right, sir.
Okay. So you select the right length of the blade, you put it into the slot there, and then you rotate it so that it gets locked. Now it won't come out. So like that you have to do it for all the 3 places, right?
Okay.
Okay.
Okay, sir.
So this is the blade. Now here you have a distraction mechanism which is either with this blade. If you hold this and you can distract, okay, and you hold this and you pull this back, right?
Right, sir.
Okay. So this is how you can distract. What you can also do is you can angle it. You see that this blade is getting angulated, right?
Right, sir.
Lock हो गया है. I think it's. So this also gets angulated and even this also gets angulated, right? So you can use them as angulations or as distraction, okay?
Okay, sir.
So once that is done, you push it inside. Now you you might ask why like this, why not like this, why not the other way around, isn't it? But it has always has to be like this. No, because you have to do an orthogonal maneuver, right? You need this area to be open, isn't it? Because if this third blade is on the other side, that comes in the way of your orthogonal maneuver. And this is designed in such a way that the third blade, in case if the window is narrow and there is a blood vessel there or an artery or something, you can use that third blade to keep it retracted posteriorly, or sorry, anteriorly. Adapter, it's there. Now at all times you have to hold the retractor. As you are seeing, I am not leaving the retractor because
Yes,
there
sir.
is no muscle here. If you are doing an MIS T-lift posteriorly, you can leave it like that because it is not going to slip anywhere. It's a dense, tough, muscular tighten, please. Okay. But here if you
sir.
lose it, it is just going to fall away. Though you have anchored the first dilator, you should always be careful. The advantage of anchoring it is that it should not fall away. But even then, sometimes, you know, the first dilator, especially if it is a hydrated, good disc, the disc just pushes your dilator out.
Okay.
And that is why it is important to always have a hold on that. So you see now,
Yes,
C-arm
sir.
shot, please. So you see now our retractor is in the anterior half of the vertebral body or anterior 1/3 of the vertebral body. Can you see?
Yes, sir. Yes.
On the C-arm, and
Yes.
our dilator is going all the way inside. Now, in these cases, I would prefer that the dilator is slightly posterior because we need to distract the posterior annulus as well. If we are very anterior, in those cases what will happen is that your anterior, there is already a listhesis, the anterior will get distracted, but if you don't distract the posterior, your listhesis is not going to get corrected. So you have to be in the middle of the vertebral body to achieve that kind of a ligamentotaxis to distract. Okay.
Okay, sir.
I usually put a pin on one of the bodies, either the upper or the lower, depending upon which one is that. And you should again make sure that in these cases L4 and L5, again there is a controversy, there is a debate on which vertebral body you have to put a pin. Or so there are two schools of thoughts. One is, why when you put a pin on the L4 body and you distract it, your L4 pin is going to stay in the same place. Your L5 pin is going to move downward, right? Now, if you think that you are close to the bifurcation, if you are close to the vessel, you have to imagine that the blade is pushing the vein away. And sometimes if there is an iliolumbar vein or some ascending lumbar vein which is arising from the common iliac, then in that case that can get snapped if you are pushing the vein too much, either directly or through this one. So I always make a decision. Sometimes if there is a doubt that the vein is on the lower part, if it is close, I probably would take the microscope, make sure that I am not anywhere close to it, and probably put a pin on the lower body itself, making sure that the vein is not coming in the way, obviously, and then distracting it so that you can go up. The other way to do that is go a little higher and put a pin slightly higher on the L4 body and then distract it so that you have enough space, but you are not retracting the common iliac that is close to the middle of the L5 body. You are not retracting that too much. Okay?
Okay, sir.
C-arm done? Okay. Now I think we will send the C-arm back and I want to show how it looks inside. Can we switch on the light? Light off. माइक्रोस्कोप आउटपुट नहीं एक मिनट इधर से कर Okay, so now you are seeing that focused.
Yes, sir. Yeah.
Okay, so see, I will remove this. I will remove the first dilator. Now you can see the fibers of the psoas there, right? Small fibers of the psoas.
Yes, sir.
It's good. It's okay for me. Are you able to visualize? Yes. Okay. Give me the distractor.
Overhead camera insert पे लगा दो. Overhead camera insert पे लगा दो.
So it is at this stage, somebody was asking the role for bipolar. Suction to me on my left hand. Suction is there?
It's there.
Okay, leave it. Give me a dissector and give me, okay, give me something. So you see, It is at this stage that I usually use a monopolar or a bipolar to see the bone there. You see that? I can palpate the bone there. Okay. I would clear this soft tissue and I will see the bone there and then put a pin. Give me a pin. Give me the holder. So this is a holder. See, again, each system has its own. Mallet. Oh, you have a longer suction tube? Yeah. So, okay. Anyways, I'll manage until then. So, okay. So, you see, that is the advantage of this third blade. It will just keep the abdominal contents or any other structure that is there anterior. Give me a dissector or a forceps. So, because of the, no, I need a long. See, this looks like the, can you see that?
Yes, sir. Like,
Can you see that strand there?
yes, sir.
Most likely, because again, usually in the live space, give me scissor. In the this one, you will see it as a, of course, a nerve-like structure with lot of vessels on it. Okay, give me knife. So now we are going to make an annulotomy.
So was it a sympathetic root branch?
Yeah, it looks like sympathetic one. Okay, so now you are going close to the vertebral body. And then I am palpating the upper end plate also with my knife and then turning. Don't twist, it should be 90-degree turn. So if you see now I am already orthogonal. Can you see that? My
Yes, sir.
instrument is going in the gap there. Okay?
Yes, sir.
Yes, sir.
And then I am going deeper. Take this, give me this forceps. So this will not go. So you see now the disc preparation becomes very routine. Once you have reached that stage, Forceps straight. Forceps straight first. All this. All this. So the other thing that we always try to take care is put our forceps in the other way, not like this. So you are seeing now? So I've almost reached the contralateral side. I can say that because I am feeling that contralateral annulus. Other thing what we do is in all these cases, preoperatively we measure the mediolateral length of the vertebral body, the depth of the disc. In this case, if you see, normally we mark it at 50 and 60. Give a marker pen and a scale, because it will reduce the radiation exposure. These are all what we used to do. Mark it at 1 and 0. Yeah.
So in the video that you showed, you were showing that end plate was removed.
Yeah, I'll do that. I have not yet removed the end plate. So many times in the cadaver, it always depends. Give me the other side. So you are able to see now what I am marking?
Yes, sir.
Yes, sir.
Okay. So now if you see, those two marks that we have marked are at 40 and 50. Now you see I am already at 50. Usually the lengths usually in Indians are somewhere around 50.
Okay, sir.
45 to 50 is the length. So once you are 50, that means you are already on the contralateral side. And you see my direction, I am going orthogonal, I am going inside and removing. Can you see the mark there?
Yes, sir.
Okay, so that is one indirect way of going. The other way of doing that is check it with CM, which we will do now, right now. But I want to remove the end plate a little more. I am feeling a little confident about the FOBs. So, okay, give me a. Okay, I have to, because this instrument is not going in. Okay, see now?
Yes, sir.
See the end plate coming off? But sometimes in cadaver,
Yes, sir.
we may not be able to demonstrate it as nicely as we do in the clinical case. Can you see the end plate coming off?
Yes, sir.
Yes, sir.
So, and then I also feel that this is a good way. See, I am not using too much force. I am just sweeping and lifting off, sweeping and lifting. Okay? So that way, even in case of osteoporosis, I am not using excessive force.
Sir, in some cases it might not be possible to
You
remove.
use a curette and remove, that's okay.
Okay, okay.
But you see now, it has come out nicely, right? Can you see?
Yes, sir.
Yes.
And then all the way there, I am not sure if you are able to see the end plate, bony end plate, you can see clearly there. Can you see there?
Yes, sir.
Yes, sir.
So this is what I feel is the fastest way to prepare your end plate. Now, I know
Sir,
I know these instruments, we use that regularly. Once I have crossed that shoulder there, you are able to see the shoulder, no? Yes. So that is almost around 40. You can see the scale.
So will there be increased chances of subsidence in osteoporotic patients in which we remove end plates?
No, we have to remove the end plate anyways. Yeah, almost one because it goes in. Yeah. Yeah. So, no, you have to remove that cartilaginous end plate, right? Otherwise, how is it fuse? You shouldn't damage the bony end plate, this forceps. Straight. You got the point?
Yes, sir.
You have to remove this. Cartilaginous end plate has to be removed. Otherwise, it won't fuse. You have regular disc forceps. That's enough, I think. I'll show you the end plate now.
So can we use drills for this purpose?
Sorry?
Sir, use of drills in this.
There is no use for drill here. Where will you use the drill?
So for the preparation of this this space and plate removal.
Do you use a drill in your T-leaf for preparing the end plate?
Sometimes, sir.
I don't think it's a, means it's, I don't know what to say. It's not recommended to use a drill for preparing the end plate. If you want to remove an osteophyte, that's okay. But again, usually for preparation of the end plate, usually you should not use a drill. Cobs, angled. Give me that. ये screwdriver. ये छोटा वाला. Angled cob, छोटा वाला. Okay, so now I am doing the same thing on the lower end plate. Can you see now?
Yes, sir.
Again, not too much of pressure. You are just elevating it. And again, we have gone beyond the shoulder. You see that? So that means we have gone almost for 40, and more than that will be. I usually do it at this stage only. I don't use a C-arm in an AP view, as you can see. Till now, I have not taken an AP view. I think that is a question that you should have had asked. But बड़ा वाला, अभी तक तो बड़ा वाला दे रहे थे, अभी कैसे चेंज हो गया? इसको ना. So because normally in an AP view, what you want to see? You want to see the mediolateral extent of your disc space preparation, and you want to see the contralateral annular release. So that is why I will take an AP view only now, once I have reached that area. Otherwise, normally in the beginning also you can do, just to see whether you are in the right direction. Because if you are in the wrong direction and you prepare your end plate, there is a higher chance. If you are looking at a disc space in a very angled way, in a superior-inferior obliquity, in that case, there is a higher chance of end plate injury on any one side, whichever side you are looking towards. I think I've already gone through the end plate there, through the contralateral. Anyways, give me the cobs. or give me a some dissector something. So now what I'll do is I'll keep this here. You see it has already gone. I'll keep this here. And take a C-arm shot. Come out. No, lateral and then AP. Yeah. Give me that holder. First dilator holder is there, no? You can remove the dilator now. Yeah. Okay.
Yes, sir.
So we are in the right place. I can move it more anterior. Shoot. No, I'm just looking at. I have already gone through. I feel that I have gone through the contralateral annulus. I'm looking at.
Should be in the middle.
Yes, that's what I'm looking at. Shoot. Okay. AP. नहीं आ जाइए.
आगे करो करो घुमा दो
आराम से उधर. हाँ.
नहीं नीचे करो लॉक कर
0 इधर तो कुछ नहीं है.
इधर कुछ नहीं टेबल आपका डालो.
हाँ. आप सीएम को इधर से लेइए और ऐसे. नहीं ठीक है, रहने दीजिए. सीएम लोएस्ट जितना नीचे होगा उतना. बस. हाँ. शूट. और थोड़ा ऊपर जाइए. ऐसा. सीएम बेस ऊपर जाइए. टेबल और थोड़ा हाइट कीजिए. सीएम और थोड़ा ऊपर जाइए. हाँ बस अभी वो एंगल. हाँ ऐसा करना है. ऐसा है ना, ऐसा करना है. हाँ वो राइट वाला निकालिए बस. आपके राइट हैंड में जो एक हैंडल रहता है. हाँ अनलॉक कीजिए. हाँ बस लॉक कीजिए उसको. बस अनलॉक कीजिए. अनलॉक. लॉक कीजिए. लॉक कीजिए. हाँ शूट. ठीक है. Okay, it is not a true AP view because the patient is rotated. Can I have some light please here? आएगा. No. Bring that microscope only. हाँ रहने दीजिए बस. Okay. Shoot. Okay, you see now I have broken the contralateral end plate on the C-arm. Can you see?
Yes,
Yes,
sir.
sir.
Now the lower one I have broken. I want to rotate my cobs and then I want to break the shoot. So the upper one is not yet broken. Okay. Yeah, give me mallet. Usually I don't use a mallet. See, with just a gentle push, shoot. Yeah, shoot. Okay. Are
Yes,
you
sir.
right?
Yes, sir.
Can you see it?
Yes, sir.
Okay. So now I have broken the contralateral annulus, so I should be able to start using my trials now. Give me a trial. Number 9. Huh? 9. You give whichever is ready, you give. It's okay. Try. No. These are shavers. So normally again, if you see the instrument, give me the instrument. Okay. So you see, this is not the 22, 18. No, 18 is there. Okay, all right. So for these are all for European and American standards. So normally these are in the height. In the height they start from 9, 11, 13, 15. Okay, the height, which is the anterior height, and these are usually around 10 degree and 0 degree. 10. So these are, so this is around 10 degree, no? 6 degree, yeah, this is 6 degree. So this is comes as 6 degree, but in case, for these cases usually, if you see the lateral view, the segmental angle is high. So usually we ask for cages which are 15 degree. Nowadays 15 degree cages are available with this Globus company also, but I don't think in the cadaver set they will be available. The next is the depth, that is the antero-posterior depth. Normally it is around 18. Now the 18 one is the one that is ideal for our patients. But here we have, for the cadaver, we have only a 22 millimeter depth, that is this depth, which is the antero-posterior depth of the implant. So the heights will be, anterior height will be 9, 11, 13, 15. The depth will be 18 or 22, 18 is the ideal one. And the length of the cage, that is the mediolateral length of the cage, you can make out here. Till here is 40, 45, 50, 55, 60. So all these sizes will be available depending upon how big a vertebral, how long a length of the cage you want. I think I have to open the annulus a little more for this cage to go in, for this trial to go in, because can I get a top light? Not coming? Or even headlight is there? Give me a footstool. Usually, again, I don't use a headlight at all. This is only to see, because the top light is not coming. Enough. This is only temporary. Yeah, give me the knife. So because give me this forceps. Give trial. So normally, basically what I am seeing is I am going in the same angle, same opening that we have made, and not slipping anterior-posterior. That is what we are seeing on this in this light. Okay. So now,
Okay, sir. Sir, can we see
Yeah.
the incision?
Shoot. Okay. You are able to see the C-arm?
Yes, sir.
Yes,
And
sir.
see, now I have entered the disc. I am already making this orthogonal maneuver and I am going in. Shoot. Shoot. I am going in all the way till this crosses the pedicle on the opposite side. Shoot. Okay. So now it has crossed. Can you make out?
Yes, sir.
And the line is the second line, that is around 45. Okay. But I don't want to remove this now. I want to take a lateral view to see. I have not entered the canal. In this, you don't know. If I have not done an orthogonal maneuver correctly, you might have gone very posterior. Okay. And I also want to see the size, whether this 9 millimeter cage that trial that we have used is sufficient enough for distraction and reducing the listhesis that we have seen.
थोड़ा सा पीछे आपकी तरफ थोड़ा बस थोड़ा टेंट था ना ऐसे X-ray.
No, KV increase. Next size 11. You see that?
Yes, sir.
Can you compare with the old X-ray? It's quite, go back a little in the same angle and give me the reverse hammer. वैसा ही नहीं ऐसा ही इसी एंगल में आप थोड़ा पीछे जाइए, मैं इसको निकालूंगा, दूसरा साइज डालूंगा, वापस आ जाइए बस. हाँ बस और थोड़ा थोड़ा पीछे बस 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 नहीं रिवर्स, the reverse slap hammer. Next size. This is. So you see now I am using a 11 size. You can see. You want to put? Yeah. Anterior, this is anterior, so this has to go anterior. Yeah, just go in and just just position at the mouth of the disc, hammer it inside a little. As soon as it goes inside, yeah, now leave, now change it as much as possible and then make it, see, this has to be perpendicular to the ground when you are hammering the later. See how much it has gone. You should not go
First line.
first line. Yeah, until the second line you can go in.
Just
Okay. Enough. I think the second line is inside. Huh? There are 5 lines. Now you are seeing only 3.
1, 2, 3, 4th is on the edge.
That's what you are seeing, 3 outside. That is the second line is there. There are totally 5. Okay. Now, huh? No. We want to see whether how much distraction is enough to reduce this listhesis. That is something you can see. But again, that depends. Aram se. Don't shake while shooting. Rotate हो गया है पूरा. तो और थोड़ा नीचे आ जाइए.
थोड़ा नीचे लो.
शेक करते वक्त आप शूट मत कीजिए. हाँ बस 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 कितना बार शूट थोड़ा थोड़ा एंगल ऐसे 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 हाँ बस बस आप स्टेबलाइज होने दीजिए बाद में शूट कीजिए हाँ शूट ओके listhesis is reduced but more importantly we have achieved distraction now obviously if you see you know it all depends upon what is your primary target. The primary target here, if there is a compression, you have to distract the posterior disc height to an extent where the compression is released and restore the foraminal height. Number two, if there is no compression or even in the presence of compression when you are doing this, the primary aim is to restore segmental lordosis. More important than anatomical reduction is to restore lordosis, which was there earlier. So I think in this case we have come to nearly around grade 1 and I think it is still rotated. Can you just rotate like this? C angle, ऐसा कीजिए, बस, हाँ बस, shoot. You see now?
Yes, sir.
Yeah, looks much better, right?
Yes, sir.
Yeah, but definitely the posterior compared to the first image. Can we show the first image and this image? Compared to the first image, I think we have achieved a good amount of distraction. If you want more distraction, it is possible. If you want more, you can go up to, you know, now it is 11, right? This is 11. You can go up to 13. It is possible to use 13 also in this case. Yes, in a freely distractible segment, you can take the average of the upper and the lower disc and put the cage there. But many times what happens is your disc is collapsed and the end plates are sclerosed, the posterior facets are little bit arthrosis is there. So usually, yeah, it is better to limit, not over distract. So this actually, there was a talk, what we have learned over the years, yes. What we have learned over the years, you know, with all these cases is not to over distract, just optimal distraction. These patients are much happier if you stabilize them. It is not about the anatomical reduction and all those things, because this is an unstable listhesis, usually what it looked like. Because the disc also, if you see, there is hardly any material inside, it was almost hollow when we went in. So,
How about the degree of lordotic cage? How much? Which one do you use?
so normally we decide that preoperatively, we measure all the cases. In all these cases, you have to measure PILL and PILL mismatch. You measure the pelvic tilt and you also see the lordosis distribution index, especially when you are doing L45, L5S1, you see LDI. Now these three are the most important factors, more important than SVA, according as what I feel. So, but SVA is also, if you consider global parameters, but in the regional parameters, you look for PILL PT, PILL mismatch. PILL mismatch should be less than 10, PT should be less than 20, and your lordosis distribution index should be anywhere between 50 to 80. These three factors have to take care. Now, in these cases, usually looking at the preoperative thing, this looks like either a high PI, high LL case, more likely type 3, type 4 curve. And usually in these cases, you have to maintain the preoperative segmental lordosis. That is the least that you have to do. Maintain the preoperative segmental lordosis. If there is a preoperative PILL mismatch, which is unlikely in this case, usually this lordosis also, if you see, there is a good lordosis that is preserved. Whenever there is a PILL mismatch, normally you are not looking at a single level disease, you are looking at a multi-level problem. So usually in those cases, you may have to go for multi-level to restore the PILL balance. And again, in these cases, pelvic tilt normally is not that much affected in single level case. But yes, if it is affected, you have to restore it to less than 20. So to answer your question, you decide the angulation based on your preoperative PILL mismatch, how much lordosis you need to restore. If there is no PILL mismatch, how much lordosis is required to maintain that PILL this one, so that we are not creating a mismatch by reducing the preoperative segmental lordosis. So in this case, the preoperative, that is what I was telling, the preoperative disc angle looked at, definitely it was more than 15 degree if you look at the first X-ray. So in these cases, you should always aim at putting a hyperlordotic cage, or put a large cage very anterior and then compress it from posterior to restore as much of, or restore or preserve as much of preoperative segmental lordosis as possible. So I think that is okay. So if you want, we can go till 13, but I really don't want to do that. 11 is good enough for this patient. Doesn't look like a big bone, and you see this we have put a 22 millimeter, and the anteroposterior length of the cage is 22 millimeter. Normally we use only an 18 millimeter, and that is why it looks like it is very close to the posterior border. But if you use an 18 millimeter, I think that should be enough. And I don't want to put a longer cage, especially whenever it comes closer to the posterior border. You should not put a very long cage, because it is close to the posterior border and it goes beyond the lateral border of the contralateral vertebral border. Then it impinges on the contralateral exiting route. So because it is already posterior and you are going beyond the border of the vertebra. So usually in these cases I select the optimal length. If it is anterior, you have the liberty of again going a little more longer, if it is in the middle. If it is very anterior, almost anterior 1/3, you should see that the lumbar vertebral body is like this. So if you are putting an anterior, the anterolateral corners are outside. You should imagine this cage in a 3D position. So if it is in the middle, you can always go for this one. Okay. Yeah, you can put. You want to? Yeah, we can put. Good. Give me the slap hammer. I think you see it is very snug. So I think this much distraction is enough. I don't want to over distract. Give. Mallet. You see it, so easily it is coming out. And if you see now, give me the microscope. No. I want to show them the disc. No, not extra disc. After preparation, how it looks. So it's important to see that. Can you see? One.
No, sir.
Can you see now?
Yes, sir.
You see the end plate, right?
Yes, sir.
So that is how you should see. Oh. Leave it. Oh, no, that doesn't work. Are you seeing the contralateral? You see the posterior annular fibers? See, you have to understand the microscope is looking at it obliquely. Microscope is not doing an orthogonal maneuver. So the vertical fibers that you are seeing at the far end, they are almost the posterior annulus. I will show. Give me the forceps or something. So you see, those are all the posterior annular fibers, okay?
Yes, sir.
Okay, see, it is almost going in there. I think I can leave it there and I will tell the C-arm to come so that you. You see that?
थोड़ा bright, थोड़ा सा bright. Okay, okay.
नहीं नहीं
मत करो.
थोड़ा ऊपर. बस बस बस.
C-arm is not focused, sir.
Okay. So those are the posterior fibers. You saw where the dissector is, right? On the C-arm?
Yes, sir.
Shoot. Okay. So the fibers that you were seeing on the microscope earlier, those are the posterior annular fibers. Give me the cage now.
Can you tell the cage, the spines, the radio? Vinay,
Yeah.
दिखा दो.
So if you see there are markers in this, you see these dots? They are all radio opaque markers. Okay. Can you see now?
Yes, sir. Yes.
So these are the radio opaque markers. There is one at the one end, one at the other end, and there are two in the middle. So normally these two, if they align against the spinous process on an AP view, that means that it is in the middle, right? And if these two do not are overlapping each other, that means on a true AP image, if these two markers are seen as a single line, not as two separate lines, as a single line, it means that it is true, means it is exactly perpendicular to the spinous process. That means it is exactly in the long axis of the disc. If it is oblique, yeah, then you will see the two in the center. Okay?
Okay, sir.
This is anterior, this is posterior. So here it is written here. You see that anterior.
Is the anterior wider compared to?
Yeah, because it is lordotic cage, no? So the anterior will be taller than the posterior.
And even the superior surface is it?
No, these are, there are different types. There are dome cages that are available, and also there are coronal wedge cages. I don't think they have it in the cadaver. Yeah, in the cadaver it is not there. So what I will do is, I will go in and
पीछे करो तो.
no, it is not fixed only. टूट गया. Give. No, it is not even gone in. I can lift it off with a forceps. Give. Or a cockers or a forceps. Okay, let me do it with this only.
Hammer.
Impactor. Okay, see ya.
सर की तरफ. ठीक है. हाथ हटाओ.
Rotation. नहीं नहीं, C angle.
थोड़ा एक मिनट.
Some more. ये ऐसा करो.
ऐसे
हाँ.
करके और अपनी तरफ.
पीछे जाओ.
लॉक करो ना इसको.
सी एंगल और थोड़ा, अभी वापस ऐसे करो, सी एंगल ऐसा ऊपर, हाँ ऊपर,
लॉक करो
और थोड़ा, और थोड़ा ऊपर, हाँ बस, लॉक कीजिए, वापस जाइए, बस, शूट, थोड़ा ऊपर जाइए, ये okay, it's not a true lateral, ऐसा कीजिए, और थोड़ा, शूट, looks okay, okay, you can take an AP. Any doubts? Yeah, please take it out. Whose gloves are clean?
Sir, there are no doubts, I guess.
Okay, if you have any questions, you can ask. I think obviously after this you have to do a posterior percutaneous fixation, and only then the surgery will be complete.
So these radiographic markers, these.
So the posterior 3 markers that we saw on the cage, so if they are in the same line, obviously the first thing that you need to see is whether the image is a true lateral image. If the image is a true lateral image and these 3 radiolucent radio-opaque markers at the posterior edge of the cage are in the same line, that means again it reconfirms the fact that your cage is exactly in the long axis of the disc. Okay, I think it can go in a little more, but it is again, as you can see, it is not a true AP view. ये इसको उठाइए.
So the middle marker should be in line with the spinous process.
No. So see, the markers make sense only if the image is true. In MIS, if you see, now you see, okay, but I completely agree, it has to go in a little more. That's why I already asked. I also felt that here also. Impactor. Mark, mallet. Shoot. Shoot. Okay, I think it's acceptable. It's in the middle. So if you see, it's slightly oblique. The image is a true. The first thing that you need to see is whether the image is a true AP view. You see, the L4 body is a true AP view, right? Yes?
Yes, sir. Yes,
Are
sir.
you
Yes,
convinced
sir.
or not?
Yes, sir.
Yes, sir.
Convinced, okay. So now if you see, the middle 2 markers have to be in the same line as the spinous process. It's almost the same. I think it is slightly oblique. If you see, one of the markers is in the line with the spinous process, the other one is slightly out. But more importantly, the lateral markers are away from the lateral border of the pedicle. I think that is what we need to see. Earlier, we used to restrict the cage to the lateral margin of the pedicle. And we observed that in the lumbar spine, the pedicles are medial. You know, it's a small mistake from our side in early days. As you know, in anatomical thing, the lumbar vertebral body extends beyond the lateral border of the pedicle. So we started putting longer cages, go beyond the pedicle. That is the, nowadays we go beyond the pedicle, and I think this is sitting all across from one end of the vertebral apophyseal end plate to the other end of the vertebral apophyseal end plate. Do you agree?
Yes, sir.
Yes, sir.
Yeah, sure. If there are any questions, you can ask, and otherwise this is how it is. It is quite simple procedure, very straightforward. If you follow the steps, make sure that the image, make sure your orthogonal maneuver is correct, and make sure that the extent of end plate preparation is adequate. In that case, it is, everything else is going to go smoothly. Yeah, we can see. Because we don't have the retractor, it's not there, no? ALIF, the L5S1 oblique retractor.
Light on.
No, we have to remove the cage. बाद में कर देंगे. ठीक. I'll remove this. A pin is there. So normally when you remove this pin, you have to make sure I think that is one more observation. I already saw that the pin is very close to the middle of the vertebral body. So there is a possibility that the segmental might be injured with this kind of a pin placement. There is a possibility, unlikely, but there is a possibility because the pin has to be as close to the end plate as possible. Now in this case you have to be careful. So for L5S1, see I want a half circle. That one. Half circle. One half. Only one half. Top light is enough.
Overhead camera पीछे आ जाओ.
No, overhead this camera is also good. What? Huh?
नहीं sir, I'm talking about recording because you will not be able to see. Do you want microscope or?
Okay. You want me to show in microscope? I can show. That is not a problem. Whichever is convenient. Give. But we don't have you have that separate one. Okay, you attach this from there. Give me the guide wire. सियाम आ जाइए. मार्क करना, इंसिजन मार्क करना है पहले. गाइड वायर दीजिए. मार्कर दीजिए. We already know the L5S1 here. सियाम.
थोड़ा इस तरफ पर, पीछे की तरफ पर. थोड़ा नीचे की तरफ. बस शूट करो.
Go down.
पैर की तरफ. लॉक करो अरे.
फिर ऊपर गए भाई आप.
ये ऐसे हो जा रहा है. लॉक करो ना सारा.
नीचे थोड़ा नीचे आ जाओ. नीचे आ जाओ.
पूरा बेस.
हाँ बस बस.
पहले हाथ हटाओ. मशीन से हाथ हटाओ.
थोड़ा पीछे जाइए. नहीं अब मशीन आगे आ गया. आपका सियाम उधर ही रहा. आप पीछे थोड़ा पीछे खींचिए. ये ऐसा नहीं. बस पीछे जाते वक्त ऐसा नहीं होना है. मछली की तरह नहीं. और थोड़ा ये भी ज्यादा करके निकालिए. ऊपर चला गया फिर से.
ढीला करो वो वाला. ये वाला. अभी टाइट करो. अभी हाथ हटाओ यहाँ से. शूट करो.
थोड़ा ऊपर जाना है, थोड़ा
थोड़ा बेस थोड़ा सा खाली बेस
थोड़ा थोड़ा, ज्यादा नहीं, बस बस बस,
लॉक करो, हाथ हटाओ,
नहीं, और थोड़ा थोड़ा ऊपर, नहीं, बस ऐसा घुमाइए, बस 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 बस, ज्यादा हो गया, ज्यादा हो गया, हाँ बस, के भी ज्यादा कीजिए, okay. So that is the L5S1 approach. So now you see your disc is there, your anterior margin of the disc is there. Now this is the angle of the disc space, okay, and then you draw the vertical. So the vertical is this. So your incision has to fall between this and this vertical, right? Somewhere in between this, the closer it is to this L5S1 angle,
Sir, can we see it? Like, we are not able to see that.
कैमरा इधर से आना है. Yeah.
मार्कर रिकॉर्ड पे मेडिकल मार्कर रिकॉर्ड मार्कर
नहीं नहीं नहीं, एक हाफ इधर इधर ऐसा आना है, ऐसा.
दिखाई दे रहा है, हाँ सेम सर.
So you see this one, this is the angle of the disc, right? Now,
Yes, sir.
now normally common sense would say that your incision should be on this line because you have to go into the disc space, correct? Right?
Yes, sir.
आप इधर आ जाइए, इधर आ सकते हैं आप, हाँ हाथ में ले लीजिए उसको.
वायर देख के, अगर वायर है तो छोड़ दो.
So normally, can you see now?
So we can only see the C arm. Yeah. Now we can see.
Yeah. So you see this is the L5S1 disc, right here. Okay. Now normally
Okay,
this
sir.
is the line of the disc. Now you should think that okay, our incision has to be along this line because you have to go into the disc space. But many times the skin here is very flexible, and that is why what you can do, you can mark your incision anywhere between there and a vertical line from the anterior margin of the disc, a vertical line which goes down like this, okay. So anywhere here between these two lines, if an incision is there, that is enough. You got the point? Did you understand the point? Okay.
Did you understand?
Yes, sir.
Okay. So now why we don't sometimes take it on this line is, in this case the sacral slope is not high, but sometimes the disc angle is like this, okay, and the incision will go almost very close to the pubic symphysis or the inguinal ligament, means along the inguinal ligament. So that is why we place it a little more higher, and we can do the orthogonal maneuver because the tissues here are slightly malleable. Now normally we take around, can I have another glove? 7. सेवन कुछ कौन सा है? दे दे दे. It's okay. Anyone, only left. नहीं, हो गया. Okay. So sometimes if it is the sacral slope is very high, it can go on to the pubic symphysis or very close to the inguinal ligament, and it becomes slightly uncomfortable to have an incision all the way down there. So we can have the incision a little high, anywhere between the disc line and the vertical line, and then we can have the this one. The second thing is we normally put it at least 3 finger breadths away from the ASI, yeah, anterior superior iliac spine. Okay, so at least 3 finger breadths. So we mark the incision from there to there. Okay, got it?
Yes, sir. Yeah.
Between the but yeah, you can mark it horizontal like this, but I always prefer a oblique incision because sometimes we do use the same incision to go to L45 as I showed in the video. Okay. So again, around 4 to 5 centimeter incision is enough. Now once we have done that, as I was mentioning in the talk, can you see this dissection?
Yes, sir. Can the cameraman zoom a little bit more?
Knife or scissor. So you see that is the aponeurosis. It is not the external fascia. So this one will be the external and internal aponeurosis that has probably merged. So let us see. I'll open this, and many times, scissor. Again, we don't go beyond the arcuate, we don't go lateral, and you can see that. You see that now? This is the muzzle and this is the aponeurosis. The
Yes,
muzzle
sir.
is turning into its tendinous attachment. Okay?
Yes, sir.
So, preferable to open it on the muzzle side. Again, you see hardly any thickness in the muzzle. You see that?
Hmm.
Okay? So again, I'm using the scissor just for convenience. This is again a blunt dissection, and you see there. You see, I have opened the muscle fibers there, and you see it is actually a single aponeurosis. Can you see that?
Yes, sir.
Okay. Can you make out?
Yes, sir. Yes, sir.
Okay. So now I'll just open that, and then I am not going too deep. You just open the aponeurosis, and you see that there is a, this is the peritoneum, this one, and that is the retroperitoneal space, fat. I think yesterday you might have seen this. Give me this, hold this. Can you see there?
Yes, sir. Now we can see
Okay.
it.
So
Yes.
we don't have to go here. We have to go there. And give me the scissor. I'll open it more posteriorly. So now you can make out. You don't have to go here. You never go here. You go here, right? Okay?
Okay.
Don't worry about what is there inside there. Just go there and like, remove this please. And like we explained earlier, go all the way, palpate the iliac crest, the inner, this one of the iliac crest, and then start sweeping the structures anteriorly, very, very gently. You will observe some strand like structures which are on the, which will restrict the movement of your fingers, and that is something that you need to be careful. So once this is done, give me scissor. Okay. So now you give me, I can already see the psoas there. Yeah, I can use the microscope.
Manoj, microscope हटाओ. संजीव देख के.
Can I, do you have a stool? No, no, sit down. Chair.
Chair जो है.
नहीं है? Because, no. No, 1 minute. Be there, Siam. Give me the, no, some dissector, yeah, some dissector. I want to see the direction before we dissect too much. Shoot. So we are already at the sacrum, right? See now? So I can palpate that, but I just want to show you.
Sir, we can only see the C-arm.
Shoot. Okay, so that is L5, right? Okay. So, anyways, that is the direction. We will check with C-arm again. Show me this. C-arm, no, be there only. This has to. मिलेगा.
स्टूल दे दो.
नहीं. नहीं. ठीक है सर, छोड़ दीजिए. Thank you. So we need this angle.
Microscope also. And CM.
Oh.
Microscope out.
Sir, we can, yeah. And now we can see.
ये top light बंद कर दो.
You can see the blood vessel. Give the dissector. Suction to me on my left hand and blood and dissector on my right hand.
Yes, sir, we can see.
Suction. Okay. So now, you see that is the psoas. Oh, okay. Okay. That is the psoas, right?
Right.
Can you make out?
Yes, sir.
And that is the place where we have
Sir,
put a
can
cage
you
there.
move the
Well, no,
microscopic
let us not show that.
Okay.
So that is the psoas. You see, that is the bifurcation. This is the external iliac. Give me another dissector rather than this. Okay. So this is the external iliac artery. That is the common iliac. Can you see that?
Yes, sir.
That is the external iliac, and that is the internal iliac. That probably is the pudendal. You go there, that is the vein. Can you see? Okay, you
Yes, sir.
retract the vein. So lot of this dissection has already happened with finger. And in a live case, it is much more easier because you can palpate your vessels, the pulsation of the vessels. You can palpate. See, it is so easy. And I don't want to say anything against Dr. Anand in a joking way. No, yeah, incision is smaller, number one. Number two, you don't have to dissect through all that fat when the patient is supine. Yeah, when the patient is supine, yeah, the gravity is pushing all the fat back towards the disc, and you have to dissect so much in order to expose the disc. And you see now, I have hardly poked my finger a few times, And you see that is the disc. Can you make out?
Yes, sir. Yes, sir.
So
We can make out.
all the retroperitoneal structures have already fallen away. And all I need to do is just dissect it a little more. And you see you are on the surface of the disc. Can you see that?
Yes, sir.
So that is the disc. So it is much, much more easier. This is the ureter. Can you see?
Yes, sir.
Can you see this?
Yes, sir. Yes, sir.
So
We
that
can
is the
see it.
ureter. And you can appreciate the anatomy very well in this case. So that is the external iliac, as I said, that is the internal iliac, and that is the probably the pudendal. I'm not so sure. I'm not very good at that anatomy. Anyways, whatever it is, we are not worried. So now you know that this is free, and you can retract. All right, and then
Yes,
you
sir.
can, use a peanut or something to dissect all these things. This is the anterior border of the sacrum, and that is the disc. You can see I am able to push it.
Yes, sir.
This is yesterday's? Yeah, it's a new one. No, it's actually very, yeah. So that, I'm not sure. Oh. Seeing, huh? Can you see?
Yes, sir.
So we don't want to go there. See, that is the heart of the hypogastric plexus there, where the bifurcation is and where the vein is. We don't want to go there because it is upper or a normally located bifurcation. See, that is the median sacral. Can you see that?
Yes, sir.
And then we, in an oblique approach, for an oblique, this much is enough. We just have to cross the median sacral. In case, if required, we can do a little more. Yeah. Okay. So now we have exposed. Take this. Is the retractor ready? Give me narrow. Narrowest blade, that one that is above. No. Narrowest. Yeah. So that is why, yeah, the 4-5 we went like this. Here we are, if you see now, we are almost parallel to the ground. Can you see that outside?
Sir, can you make the, yes.
So we
Now
are
we can
almost
see.
parallel to the ground here.
Yes.
So that is why it is like a leaf only. What you are seeing with an exposure from midline here and like this yesterday, today we are just in the lateral position with a much faster and an easier dissection. We are able to reach the same trajectory. Give me the retractor if it is ready. What is the length? Give next size. So you see, even though the patient is not very obese, we are already at 140 centimeters, means 140 millimeters, 14 centimeters. So this is a very deeper approach, and that is why we need to be very, very.
Sir, there is a doubt actually.
So can you use the OLIF retractor system in this, or do you need a separate retractor
No, this is
system?
a separate retractor system. So I'm retracting the vein that I have already dissected, okay? Yes, fix it please. नहीं ये ऐसा नहीं होगा. हाँ उसको कीजिए, उसका उतना ऊपर मत लीजिए, नीचे लीजिए इधर. हाँ लूज कीजिए. छोड़िए. हाँ अभी नीचे लीजिए उसको. हाँ हाँ आप उसको टाइट कीजिए पहले. एक मिनट. नहीं, the pressure should not be transmitted onto the blade. One minute. Tighten that. Enough. No. Tightened. Either. Okay. No. Yeah, loosen please. Pull it back. Enough. Leave. Okay, fix it. Tighten this also. Okay, good. Give me the next one from here. So you are seeing now. So this is how
Yes,
your
sir.
exposure will be. Now
Yes, sir.
I know that because our orthogonal manner is like this. So normally, 1 minute, Surya, 1 minute. Normally, why I put this? I will usually put this retractor like this because it will help me to do my orthogonal maneuver. Okay, because that is along the line of the contralateral vessel. If you do like this, especially if you are using a broader retractor, this edge will come in the way of my orthogonal maneuver. So I will usually put it deeper and put it like this. And if required, if there is too much of a fat that is coming in the way, we use one more retractor like this. Okay? And if the bifurcation is close, then this will become the bifurcation retractor like this. And another laterally down. Okay? So like that. And once that is done, give me a broader one here. So you should make sure that you have exposed at least 3 centimeters of the anterior disc space. And I think in this case, it is quite a big exposure, quite a good size. You have your ALIF cages, sir? Yeah, you want to put a cage? Can you fix this here? No, it's. There is a median sacral vessel, sir. the median sacral vessel that we are seeing there, that is the midline. Show me the forceps. Yeah, yeah. Yeah. This one, sometimes if they are very loose, they may, but otherwise usually they are under the periosteum. So that is a rough indication. It's not like a true indication, but that is a good rough indication that that is the midline. Hold this. Leave, you leave. कहाँ से है? इसको इधर से लीजिए. नहीं. हाँ. ये छोटा वाला नहीं है. There is a quarter. हाँ, बस. One minute. Fix that down. Oh, slowly. It's okay. ये क्यों नहीं रोटेट हो रहा है? नहीं, एक मिनट, उधर छोड़िए. इसको टाइट कीजिए पहले. नहीं, इसको छोड़िए. रिंग को टाइट कीजिए पहले. Okay, good. Give me one more. नहीं, इधर. So basically, if a vein is seen, it's better to retract. Okay, we'll do that later. You get it ready. Give me knife until then. Now you are able to see the anterior half of the disc, right? Okay, so
Yes,
the
sir.
median sacral vessels, you just coagulate, suction and knife.
छोड़ दो. ये आ जाओ बाहर. Knife दो.
So now you see that is the upper border of the sacrum, right?
Yes, sir.
Okay, so that will be the upper border, and then whenever you have an exposed part of the vein like that, you see that there is an exposed part of the vein, right? You have to be careful when you are moving your knife. You should retract that or make sure you use a proper whatever that retractor is there in the right position. Even suction also. Sometimes if you put it roughly on the vein, sometimes it can get torn. It can get sucked into that. So you see that? Now
Yes, sir.
usually the median sacral you coagulate and cut, but here you can take the liberty of cutting directly.
Do a complete discectomy, like in above levels, or here you do leave a remnant on the opposite side.
Opposite side in the means?
Right side to be, can we still do a complete discectomy at this here through this approach?
Yes. Why not? So the size of the cage that you are going to use will depend upon the extent of discectomy that you can perform. Number one. The end plate preparation that you do again will determine the rate of fusion. So it is very important to remove as much disc as possible. I think that is some bowel loop. You got that third retractor ready? So you see, I'm actually now scraping the bone with the knife itself just to make it faster. And done. I think we can. You see, you see that, no? I'm removing the end plate also with the knife.
Yes, sir.
Okay. So under microscope, it may not look like much, but we have incised the entire disc almost. Give me a bigger disc forceps. No, it slipped. Release. Yeah, fix. Do you have the other retractor ready? Big one. You see?
Yes, sir.
Can you see the size of the disc that we have removed? It's in one go.
Yes, sir.
You can see the annular configuration also, everything. Take this. Okay. This is not sitting properly. Release. It's slipping again and again. Fix. Tighten it. Give another retractor. Release this. This one. Okay. Fix. No, pull no. Just fix it there, enough. Saksh. Tighten. You can see that, right? Disc forceps. Take this. You want me to change the microscope? So normally, even this one, this part that is coming out, even we want that to go out, but that is just some fat and all that is there. So you don't have to go too much contralateral. You see now, I don't have to go like this. Again, the same maneuver that we did at L2 to L5. Now here, we are going like this. Okay? Yeah. Up to down. You see now I am perpendicular to the floor.
Yes, sir.
Give a curate. Cobs kodila andre cobs. You can see that end plate coming off, right?
Yes, sir.
And you see indirectly you can see how much you can distract. Can you make out?
Yes, sir.
So that is the posterior annulus. Can you see?
Yes, sir.
Just like ACDF, what you see in ACDF, no? Give forceps. You see how much end plate is there, even though we have scraped it with a knife. Can you see that?
Yes, sir.
So usually at this stage, of course now for demo we are using microscope, but if you see it is better to do without that. I keep the C-arm in case if navigation is there, that is good. Otherwise I would have, in this case, because navigation is not there, I would have told the C-arm to come in to see the posterior extent of my preparation, but now I am relying on my feel. You see now it is giving away there, right? That means
Yeah.
that the posterior annulus is also breached.
Yes, sir.
No, you don't have to. You don't have to. See the end plate. See the entire end plate. Can you see?
Yes, sir. Yes, sir.
Keep it. So you see now that is going inside the disc space. Can you see that?
Yes, sir.
It is going inside the canal like that. There is a breach there. Okay, but I think enough. Trial. Trial small size. Huh? No, yesterday in ALIF you used, no. Same thing you give. Whatever you used in ALIF, the same thing you give. No, not the cage. The cage also same. ALIF cage only, there is no change. Give me the trial first. Yes, same cage. Trial is not there. No trials are there. Okay. How do we assess check the size? Huh? No. Then we can just check with a scale. Otherwise, we can measure on the X-ray how much is the height, the anterior disc height. OLIF trial we have not used. I think we can use it, I think. एक स्केल कट करके दो तो फिर 2 सेंटीमीटर का स्केल 2 सेंटीमीटर पे कट करके मुझे दो. एक गॉज दीजिए लंबा वाला. नहीं है क्या? वो दीजिए, केजी दीजिए. कौन सा साइज है? हाँ 11 दीजिए. Can we cut it 2 cents? So one thing is, while putting the cage or the trial, you have to make sure that this soft tissue is not in the way. Otherwise, the cage will pull this inside. The soft tissue will be pulled inside. So these are all very, yeah. So I think it should be around 13. Okay. So around 13 cage should be acceptable. Do you agree? Yeah.
Yes, sir.
Give 13. Holder. Give. Cockers, long cockers. Straight. And then impactor. Removing will be your headache. Huh? What do you have to hold it? Any instrument. Give me the disc forceps. Small disc forceps you gave, no, that time? Very thin. You think a forceps will hold properly? We are now trying to adjust. Give me what you have. Huh? Not dilator holder. The disc forceps. Okay, guys, any questions are there? You can ask in the meanwhile, as we are trying to find out what instrument. Brother, it's here, no? Give that.
Do we have any questions? No.
And take an impactor. Okay, so now you see, as I was showing in the video, we have an oblique hold. Now this is a A-lift. Oh, sorry. What happened? Just tighten it. Can you see?
Yes, sir.
Yeah.
Can you move
So
the camera?
now if
little
you
up?
go in this direction, it is going to the contralateral side. You have to go like this.
Sir, can
Isn't
you
it?
move the
Now
camera?
in a holder also, when you hold it, obviously you can't push it entirely with the holder. Give me a impactor, mallet. So now what I am doing is I am trying to push the ipsilateral side first, and then yeah.
So please, can you zoom out a little bit?
Can you see?
No, sir. The cage is not in the center. Now it is.
Now it is?
Yes, sir.
Okay, so what I was trying to do is you see now this is our angle of approach, but we don't want to hammer it in that direction. We have to make it horizontal to the ground, both, and okay, and then I will turn this a little more. Okay? Looks okay, right? Yeah. Give me impactor, the round impactor. Okay. Give me the screw. Siam aa jaiye, Siam. Guys, you are okay?
Yes, sir.
Yeah. Give me CM. Microscope has to be. हो जाएगा, हो जाएगा. नहीं, 1 minute. Let me get up. Yeah. Okay. Looks good.
X-ray image, John. X-ray image.
No, they can see. I think this ring is in the way. So what we can do is reposition this. Can you release that a little? Yeah, from there. Fix it. Okay. Can you shoot now? All right.
Yes, sir.
Okay.
Yes.
Yeah. So we have that now, and then we can put in our screws. Dr. Surya, you want to come? Come. So I'll just show you how, but you can put it. Okay, now can you see in the microscope?
Yes,
Give
sir.
me that screw. All first. All. Tap and then screw. The retractable all. Angled. Huh? No, you see, when you bring for a cadaver course, you should bring the right instruments. The people who are watching, they are learners. We can't teach all these things to them. We can manage it during surgery because we have done it. But for people who are seeing it for the first time, this is not the way to tell them. Understood? Yeah. So normally we have an angled awl. So this is a retractable awl. Can you see? So it comes out sharp like this with a guard, so that you don't injure the vessel while going in or while coming out. It is there, no? So you see, for this, you need to do that, Surya, and then mallet, hammer. Similarly, for this one also, you need to go to the right angle and then mallet. Okay. I think 2 screws are enough actually. No, this will go only that, whatever that length, around 2 centimeters or something. 1 minute. Huh? And after that, the screw you can choose around 28, 30, you can easily choose. One minute. No, it's okay. It is a variable angle screw. You need to make sure that you can check in the CM. If you have a doubt, please check. But what will happen is you have to just engage that in the hole and it will go in that same direction. Take a mallet if you want, or you can check with CM if you have a doubt. Okay, it will go in the same. It will go inside. Enough. It is touched. No, you just rotate this handle. Yeah, and it will come out. Just rotate and pull back. That is like a screwdriver. Yeah. Ju- Guard hai, but yeah. Yes. No, put off a screw. The first one, because it will variable. Give 28 or 25. Finished. You want me to hold? Yeah. Give me a. Huh?
The cage tilted slightly.
But is it going in the same hole that you have made? Yeah, it is gone in. You can. It's already inside. Shoot. Go in. Shoot. Yeah. Good. Enough. It's gone in, no? नहीं उधर. Next, all upper vertebra one screw. हाँ सेम साइज. ये कितना है? हाँ सेम साइज. So just angle like this, so that it is in the midline. Yeah, it will appear in the midline. Bus. It has reached the. Yes, that's all.
So we only put 2 screws.
You can put a third one also. In this case, you can put a third one also. No, it is good. What do you mean?
The screw was
Because you have already. It's an osteoporotic probably. Huh?
it was mobile. The engagement was not.
It's okay. You are. Yeah, enough. You can remove the retractor and take a X-ray. Shoot. Okay. Yeah. Good. Chalo. Thank you.
We can break for the lunch.
Any questions?
Mike,
It's okay.
any questions?
We
Any questions?
Okay. Okay. ठीक. Thank you.
Thank you. Thank you.
ठीक है. We can.
Ah.